Good morning, everyone. We are about to resume our meeting. Welcome back to the very final day of a series of meetings that the Center of Medical Ethics and Law has organized. So we're ending up, or rather, I should say that we're ending with a high note. So thank you again to everyone who's with us today and also online. We, I think, had a series of wonderful discussions yesterday, all very insightful. My hope is that we'll be able to pick up on a number of the points or discussions that we've had and to see how we could address some of the challenges that we've highlighted. For today, we are going to have a more topical focus on AI and some of the related developments, as we shall hear from a number of our colleagues. So with this, starting us off is our colleague Rohit. So Rohit, as you see, has done a lot of work in the policy space. So he speaks to us in his capacity or wearing his Guard P hat. So otherwise, Rohit is also closely linked with WHO. Actually, he's going to speak to us in his capacity as both, Guard P and WHO. So Rohit is going to give us a brief introduction of Guard P, just in case some of our colleagues are not as familiar. And then also, of course, how AI is being used to help advance the development of antimicrobials. So with this, Rohit, welcome again. The floor is yours.
Great. And so, I'm going to plow through this, recognize. And so, yes, I'll speak both from the perspective of my work with the WHO and with Guard P, but I'll explain Guard P in a bit. And this will focus on broadly around AI and AMR, and then specifically on some of the benefits and risks of using AI to develop new treatments for antibiotic resistance. So this is an outline, and I'll start with focusing on the broken antibiotic market and Guard P's response. So I think, as a couple of people alluded to yesterday, research and development for antibiotics has sort of fallen behind the pace of resistance, which is, of course, driven by many factors. And so that has become a major part of the antibiotic resistance crisis. And we're not necessarily in a better situation now. Probably over the next decade, only about 2 to 5 antibiotics will emerge from the pipeline that provide an additional therapeutic benefit beyond what is currently on the market. And that's both because of attrition and also because a lot of companies aren't developing novel compounds, but are just sort of developing products that really don't provide an additional therapeutic benefit, or sort of known as Me Too drugs. And from the industry's perspective, one of the reasons that we don't have new antibiotics coming onto the market is for pharmaceutical companies. They estimate their cost of research and development, taking attrition into account, to be about $1 billion. And the revenues that they can gain once an antibiotic comes onto the market does not allow them to either recover those investments in research and development or to earn a healthy profit. And this is especially because when new antibiotics come onto the market, you want to use them as little as possible, or to use them as reserve antibiotics. And this is during the period when companies have a monopoly and when they generally try to earn as much revenue as possible. And the challenge from an industry perspective is not just that they can't necessarily make a lot of money from when they bring new antibiotics onto the market, but the opportunity cost of developing antibiotics usually discourages them from investing in this area, especially when you compare it to areas such as oncology. And so you see, of course, significant differences in the amount of money that's being put into the private sector for cancer research, for example, versus antibiotic research. And this ends up often being mirrored by the public sector in a lot of countries. And so the result is that you have lots of the larger pharmaceutical companies basically shuttering their antimicrobial or anti-infective programs. What you have had is a lot of smaller companies emerge over the last decade, and some of them are developing new antibiotics that actually provide an additional therapeutic benefit. Others have developed somewhat useful antibiotics, but because they don't get a lot of market share, these companies have gone bankrupt. Now, the challenge is not just about the fact that the antibiotic market isn't working, it's that it's not geared towards the greatest public health need, which is in low and middle income countries, So of the 1.3 million people who die every year from drug-resistant infections, most of those people are situated, especially in sub-Saharan Africa and South Asia. But what you see is most of the new antibiotics under development or that are coming to market are not necessarily geared towards their particular needs. And this isn't just as it relates to populations in general, but especially for children. 1 out of every 5 deaths due to drug-resistant infections is in children, and 99% of those deaths occur in low and middle-income countries. But what we see across research and development for antibiotics is pediatric neglect. So we don't have child-friendly formulations of older antibiotics. Of the newer antibiotics that have been developed over the last 2 decades, very few of them can actually be used in babies who have a significant burden of disease from drug-resistant infections. And we don't necessarily see a better situation today. So there's 42 adult antibiotic clinical trials and only 6 in babies. And so generally what you see, and this is actually for most infectious diseases, is antibiotic development for children trails that of adults by nearly a decade. And the issue of neglect of low and middle income countries is not just about research and development, it's also about access. So, and this is driven really by 2 factors. A lot of new antibiotics are simply just not registered in low and middle income countries and even often in high income countries. And they're often too expensive to be used in those countries on the basis of what households or governments can pay. And so for a lot of us, and this includes myself, that used to work on issues around access to AIDS medicines, this is very reminiscent of what we saw at the height of the AIDS crisis at the turn of the century. And so we're seeing the same sort of story occurring again with antibiotics. So this is sort of where GARD-P was developed, and this GARD-P was founded in 2016 by the World Health Organization and the Drugs for Neglected Diseases Initiative. It's a not-for-profit partnership that works with partners in the public and private sector to develop and to ensure access to new treatments and new combinations to treat drug-resistant infections. And so this is what GARD-P's medical focus on, and these are really some of the most urgent challenges in AMR, and they're especially urgent challenges for low and middle income countries. So sepsis in children and newborns, serious bacterial infections in adults, and sexually transmitted infections. And GARD-P works across the antibiotic development lifecycle, especially focused on late-stage development, so phase 2 and phase 3 clinical trials, and ensuring access to new antibiotics for health systems. But it also does some early-stage discovery and preclinical research, which is not being covered by other actors. And this just kind of also gives you a sense of what the current governance of AMR looks like today. Okay, so I'm now going to switch and sort of talk very quickly about the ethics and governance of AI for health and sort of the foundational work that the WHO has done in this before then looking at the use of AI in drug development. So in June of 2021, the WHO published new guidance on the ethics and governance of AI for health. And this was based on 2 years of work done by an expert group of 20 individuals from around the world who work across AI for health in different capacities. And this guidance tried to look at the opportunities or benefits and the ethical challenges and risks of AI. It tried to identify consensus principles that could maximize benefits and minimize risks. It looked at different forms of governance of artificial intelligence, but also sort of looking at some of the challenges of implementing those types of governance, and then put forward a series of recommendations as well as checklists for ministries of health, designers of AI, and treatment providers. And this is an overview of the key ethical challenges that we identified through the work with the expert group. I'm not going to go through these here, but I will come back to some of these in talking about the use of AI in drug development. But essentially, you know, most of these essentially in any use case of AI in healthcare or medicine, you will see some or all of these concerns come up. And so the challenge is really to think about how to address these different risks and challenges, and especially in low and middle income countries. And these are the principles which the expert group developed and which really formed the foundation of our work, especially in terms of informing governments to think about the types of policies and laws and regulations they should put in place. So the first principle is protect autonomy, and that includes, of course, privacy and informed consent. The second is to promote human well-being, human safety, and the public interest, essentially to do no harm. The third is to ensure transparency and explainability, so addressing the black box problem with AI. The fourth is to foster responsibility and accountability. AI has a lot of different actors who develop and deploy the technology. So the question is, you know, where do you allocate responsibility? The fifth is to ensure inclusiveness and equity, or essentially to avoid bias and discrimination, and to ensure you can maximize the use of AI for as many people as possible. And the sixth is to promote AI that is responsible and sustainable. It's responsive and sustainable. which means to mitigate the environmental impacts, such as its carbon and water footprints, but also to ensure that it's sustainable as it's used in health systems and for healthcare workers. All right, so now the use of AI in drug development and delivery. So what we've seen over the last decade is this really explosion in the use of artificial intelligence and pharmaceutical research and development. And this can be, especially seen in terms of the cumulative investment in AI for pharmaceutical development, and also a large number of companies that have emerged that either are using AI across the drug development cycle or in one part of it. And also a lot of the larger pharmaceutical companies are making use of artificial intelligence in, distinct divisions or departments. And the way to think about AI, perhaps not as much now, but in the longer term, is that eventually all new medicines and vaccines that are approved will have been touched by AI at one or more points in its life cycle. And this just sort of lists out the different ways in which artificial intelligence is being used, or these different use cases. And this continues to change very rapidly as companies and public sector researchers are experimenting with the use of AI to try to optimize different parts of the drug development cycle. I won't go into this in any detail, but the guidance that we'll publish next year sort of explains how this works. And there's also already a lot of literature on these different use cases of AI right now. And there are some potential benefits that we're already seeing with the use of AI for pharmaceutical research and development. So for example, DeepMind, which is Google's AI, department or company, is already engaged in collaborations with a wide range of public sector and not-for-profit researchers for developing new antibiotics. And that includes the GARDP, or the Global Antibiotic Research and Development Partnership, both to identify targets and compounds for addressing specific drug-resistant infections. We've seen the Coalition for Epidemic Preparedness Innovations, which is responsible for developing vaccines against pandemic threats, including during COVID-19, funding different companies or research programs that are trying to engage in AI-based vaccine discovery. And, AI plays a very important role in the development of mRNA vaccines, for example. And there are academic collaborations, to the extent that they have the resources to do so, to identify different compounds for public health need, including new antibiotics that have not yet, of course, gone through clinical development. And I should say for all of this, that there are medicines and vaccines that have come out of the pipeline that have been touched by AI, but there's, of course, no example of any compound that was identified by AI that has actually been approved. Most of those compounds are only in phase 1 or phase 2, so it's to limit the hype around this also. But then the question becomes, are we really changing anything, or are we really just still looking at a broken antibiotic market? And I would say that the use of AI does not alter the status quo of the pharmaceutical market. So most of AI-based drug development, and those were examples I gave, is basically dominated by private investment that applies to the commercial priorities defined by the pharmaceutical industry. And even if you take, let's say, the profit motive out of the equation, most researchers and companies are already stating that they're going to focus on areas of drug development for which there's already adequate data. So where there's a lot of commercial need, or where there's a lot of pre-existing research. And that even applies in infectious diseases, where you see most of the AI-based research focus on AIDS, TB, and malaria and COVID-19, which makes sense because that's been the locus of investment for most infectious disease research over the last 2 decades. And a lot of companies, the way they think about AI-based research essentially is to speed up drug development and not necessarily to improve the quality of R&D, even though that has the biggest benefit. So what we're talking about is basically to shorten the drug development pipeline, because what that means is it extends the effective patent life of a medicine or vaccine. So you get 20 years. If you get regulatory approval a little faster, you can sell your medicine under patent for a bit longer and earn more revenue. And in fact, not only is it about the status quo, but we could be going in the wrong direction. So a lot of us have heard the terms, precision medicine and personalized medicine. And AI is accelerating this sort of move towards these 2 forms of medicine. And I think the buzz around this is it makes, therapies more effective. But what it could really lead to is industry just focusing on, smaller cohorts of people who can pay higher prices, and not the people who are the sickest in our healthcare system or the poorest. And specialized AI companies, they're not developing new medicines. They're identifying compounds and then selling them on for a lot of money, or they're developing specific technologies and licensing them out for larger companies to use. And so this sort of establishes then a need for those who acquire compounds or license technologies to try to earn, of course, a lot of money on the basis of those acquisitions. And so these trends may ultimately lead to the development of AI-based medicines really only intended for the wealthiest, so designed and priced for those populations. And so for antibiotics, again, antibiotics are the cornerstone of modern medicine. When you think about many of the things that we take for granted, whether it's cancer, whether it's surgeries, whether it's, again, infectious diseases, we need antibiotics in order to use most of our medical procedures, but they're already heavily disfavored in our current system. And the use of AI could actually widen this opportunity cost that we already see between antibiotics and other areas of drug development. So again, AI may make it easier to develop and identify new antibiotics, but that doesn't mean that those who fund, control, and deploy AI-based technologies, which again are, especially in the private sector, are going to apply it to this core need. They already do not today without the use of AI. So now just to talk about some of the ethical risks and governance challenges with the use of AI in drug development. So not specific, let's say, to AMR. So these are some of the broader risks and challenges that we've identified. And I think one that's interesting that, perhaps doesn't appear generally in the use of AI in healthcare is the biosecurity challenges. So of course, AI could design and identify new compounds. It could also develop toxic compounds or things that could be used for, for the wrong ends. And these are just some of the other broader risks and challenges. To focus on the data justice related concerns. So one, of course, that we hear in all forms of AI is the concern around bias. And again, biases that could be encoded in data sets could carry over then to algorithms that select targets, compounds, or biomarkers. And these targets, molecules, and biomarkers, therefore, will only be appropriate or can only be validated as appropriate for the populations that are represented in the data sets. And of course, this is already how clinical development works today. We develop medicines for one population, and then for the rest of the world, we have to hope that they work appropriately. And algorithms are simply going to reinforce that and potentially deepen that inequality. There's a tendency now for drug companies to start to use AI to basically identify people that could qualify for clinical trials. So there's also this benefit of using natural language processing for people to basically search for clinical trials that could benefit them. But there's also companies that are using artificial intelligence to identify people that could qualify, but that brings up serious concerns about informed consent and privacy and whether or not somebody would want to be proactively contacted. A lot of the uses of AI require clinical trial data to be farmed out to third parties, but again, this brings up real concerns over data that is collected by one party that has consent, then wanting to hand it over to others to basically use that data for specific clinical purposes. There are a lot of public-private collaborations. Again, GARD-P is engaged in a public-private collaboration with DeepMind. We see a lot of examples, especially in the United States, of hospital systems that are working with companies to basically take the data that they have accumulated and then apply it to developing new drugs. And there's a lot of concerns that are emerging with the governance of these public-private collaborations and ultimately who benefits from these partnerships. And then finally, a lot of large technology companies are moving into this space, Microsoft, Amazon, Google, and others. But whether or not they have the right culture and practices to work in healthcare is an open question. These are companies that are just now shifting into healthcare compared to a lot of pharmaceutical companies and undifferentiated healthcare companies that have had to adjust to how healthcare works. And so I think there's a lot of concerns as to whether they have the right culture and fit. These are some of the challenges with governance we've identified, and I'll just quickly talk about a couple of these. So with the governance of data, and I think this was talked about yesterday also, with a lot of the data sets being basically accumulated and cleaned and curated in the private sector, and these data sets are not being made available to third parties. So whether the public sector, not-for-profits, even smaller drug companies that could use these data sets for public health purposes, such as developing antibiotics. Intellectual property for large data sets is not guaranteed, but some countries and jurisdictions are providing it. And that sort of reinforces the power that companies then have over these data sets. There are, of course, examples of open data efforts. There's the trusted research environments in the United Kingdom. There's the European Union's health data space, but these are still, fairly small compared to the efforts that exist between pharmaceutical companies. And ownership in intellectual property is not just about the data, but ultimately, what should we do with medicines that are commercialized, that are used and that are developed in part by the mining of data originally provided by individuals for non-commercial purposes, or that use data as well as public funding and publicly funded technologies. There's also now a rush to patent algorithms that are used in drug development and also in other parts of healthcare. And again, the patenting of these algorithms, if it holds up, will mean that only large pharmaceutical and technology companies will control these algorithms or will only license them out to people who can pay very high prices for them. And intellectual property protection, we're seeing not just in drug development, but elsewhere is being used by many firms and investors to justify a lack of transparency. And this is just around regulatory oversight. So some of the challenges that regulators have today with trying to basically make sense of the use of AI in drug development. So the explainability of AI tools, concerns potentially over data quality, including bias that could affect, whether or not they could deem a medicine safe and effective. How do they coordinate with other government agencies, including data protection authorities, which is something that at least some countries are thinking through. Whether or not these AI-based companies developing medicines are going to be transparent on a confidential basis with their source code, data sets, and the performance of their algorithms. And over the last 2 decades, we've seen a lot of convergence of regulatory standards in a positive way. So, how do we ensure that governments can work more closely and collaboratively with each other to approve new medicines and vaccines, while also ensuring that they don't create barriers to access? And now what we see with AI is that we're going to have a lot of divergence in regulatory standards globally, which creates complications both for developers as well as for governments. And so some ways forward, and this I actually don't have a lot to say on. This is something that I think we'll start thinking about next year. When I think about the pharmaceutical industry and accountability, I've worked as an AIDS activist starting 25 years ago. And the way that we moved forward with actually changing industry practice was through, broader public engagement and awareness raising to force transparency and to set better practices. And the concern, and this is more anecdotal than it is sort of, let's say, evidence-based, is what we're seeing with the use of AI in the pharmaceutical industry is people are seeing this just as a tool and not as a platform that is transforming how the pharmaceutical industry works and ultimately what priorities it sets, what it develops, and how it commercializes new medicines. And unless we change that mindset about AI, ultimately who will benefit from this will be, again, a narrow population. I don't think there's going to be a way to obviously change the mix of private investments towards really focusing on commercial priorities and personalized therapies, but governments can take steps to improve the use of AI for public health needs, such as building public infrastructure, ensuring that they manage intellectual property in a way that ensures that algorithms and data sets are not held within the walled gardens of technology companies, and to put much more public investment into academic and not-for-profit and well-governed public-private efforts to develop new medicines to address unmet needs. And again, the amount of investment we're seeing, for example, in AMR, commensurate to the actual burden of disease is just not there. And so, whatever critiques we have of the private sector, governments are still not putting enough funding into ensuring that we're developing new medicines and we're ensuring that they're going to be accessible where they're needed. And laws and regulations for AI. I mean, this has been a challenge, as everyone knows. I think the EU, I think it's actually last night, the trialogue that they've had to develop a new AI Act might have finally reached its conclusion. But what was interesting about it was the foundation models that are now the center of AI and also for AI for drug development. There was a lot of challenge in trying to regulate these appropriately, in part because of a lot of pressure from the technology industry. And I think one challenge for regulating the use of AI in pharmaceutical R&D is going to be the lobbying power of both pharmaceutical companies and tech companies. If there is going to be one opportunity for making changes in the near term, it's going to be the new rules that are being written by both the US FDA and the European Medicines Agency to try to think through how to use AI in pharmaceutical development. And again, this is going to be because most new drugs and vaccines are first approved there. And so they ultimately have space to be able to govern in some ways how companies use AI. And the WHO itself, we're considering developing a new expert group that will examine the use of AI in the pharmaceutical sector and ultimately what mix of policies and practices the WHO should both introduce into the WHO and then also advocate with governments. And that's it.
Thank you very much, Rohit, for this very helpful update and for sharing your insights in terms of a number of issues that we are engaging with. Well, moving on to our next presenter, continuing on the data and AI theme, right, would be Dr. Celine Chui. Dr. Chui, welcome. So Celine is with HKU. She has a joint appointment with the School of Nursing as well as the School of Public Health.
So thank you for giving me this opportunity to present some of my study. So my research work is more on, bringing into the local perspective, what we've been doing in terms of compacting AMR in the local setting in Hong Kong. So I specialized in using electronic health records in Hong Kong. So I'm gonna go through some part of my journeys, how I utilize the electronic health record to contribute to the field of AMR research. So just a little disclosure, the study that I'm gonna focus on is actually supported by a pharmaceutical company and some other grants that I received, not related to the work. Okay, so the question and the title of this presentation is, how is it possible for us to leverage electronic health records to improve the antimicrobial resistance surveillance in Hong Kong? So when we wanted to explore that, there are some questions that we have in mind. So why we cannot do it? So it's usually revolving around the data, whether we have the data available, whether it's complete, and whether it's credible. So I notice a lot of the audiences here are from different places around the world. So I'm gonna quickly go through how the Hong Kong healthcare system is. So mainly we have the public sector and the private sector. Public sector mainly managed by the Health Bureau, which branches off to more public health related services and also interventions done by the Department of Health. And then more of the hospital service done by the hospital authority. In the private sector, it's a pretty, I would say, a free market where there are hospitals and also general practitioners. We have Western medicine, Chinese medicine, dental care, etc. in the private sector. The difference is for public sector, it's highly subsidized by the government. Whilst the private sector, I mean, it's mostly out of the pocket by the client or covered by insurance. And insurance is not mandatory. So in terms of the market share, for outpatients like general practitioners visits, 60% are in the private, 40% is in the public, whilst for anything that's related to the hospital, like hospitalizations, majority is actually covered by the public sector because of the it's highly subsidized by the Hong Kong government. So anything that's fall within the hospitalization, we're pretty confident we have pretty good coverage of the data. So where do we obtain the electronic health records in Hong Kong? So as I said, mainly in the public sector. And because it's related to hospitalization, a lot of them are from the hospital authority, the data source, the data collected by hospital authority. And there are different ways that we can acquire the data, which I'm gonna also go through that in a minute. So the hospital authority, major public funded healthcare provider in Hong Kong, itself, when it first established in the early 90s, they already established a computerized clinical management system where everything that happened within the usual routine clinical work would be recorded electronically. And that helps collect the electronic health records where it accumulated a very rich resources where us researcher epidemiologists would be able to conduct research. So up to date, it contains over 12 million individuals, and that includes people who died. The service covered by hospital authority across whole Hong Kong includes 40-something hospitals, specialist outpatient clinics, and also general outpatient clinics, the general practitioner. So we actually have a lot of service outlets, health service outlets in Hong Kong. All the data are stored in one single system, which is the clinical management system, CMS. And there are actually a lot of peer-reviewed publications, medical research published using this data, over 400 to date. So what type of data is included in the electronic health records in hospital authority? So any diagnosis procedures coded in ICD codes, pretty standard. Prescribing records, admission, discharge details, and of the hospitalization, laboratory and pathology results, including the antibiotic susceptibility test. So this is what we wanted to focus on. Speaking of the subject matter of AMR. We also have mother-baby link, so something that's pretty rare in a lot of electronic healthcare system and or records databases in all over the world. We have the death record, which is confirmed through the death registry in Hong Kong. So we actually have done some validation data, the validation work on this. It's very accurate. So all of the data, because it's the purpose of developing the electronic health record at the very beginning was to facilitate the clinical management. So all of the data is available in individual level. So this is just a illustration how different data is transferred into one single data source. So we have the CMS, which the clinicians, the interface where the clinicians can input the data, record all the routine clinical data. And then we have some data that's automatically transferred and or recorded once the patient it's entered the health or used the health services in Hong Kong. So all of these different data sources, they were all transferred into a clinical data repository in the hospital authority, where the structured data are available in a system called CEDARS, and then we can access that data through the intranet of any hospital authority computers. So to access the data, I missed out one point, but of course we have to obtain an ethics approval, and that's the hospital authority ethics approval. And because I'm affiliated with HKU, so we also the ethics board, it's HKU and the hospital authority. We can directly acquire the data through simply purchasing it with a cost. But then in order to purchase it, we have to give a very detailed proposal and also a data request form, including all the columns that we need to HA. And HA, they have a data access board where they would review all of these proposals and data requests, and they would give out the data de-identified and also make sure it's we request what we needed. So we don't get the whole data to ensure patient confidentiality. And then another way is CEDARS, as I mentioned before, clinical data analysis and reporting system. That's more of a data collection that's usually done by the researcher, where we go to the computers in HA, we access through the intranet, and then we collect the data where we can analyze them. All of these ways to access the data are actually coming from the same data source. It's just that whether we go through HA to access it in a batch, or we download or access it bit by bit through CEDARS. I'm going to focus more on CEDARS because this CEDARS actually has very high granularity. Like the timeliness is just T-2 days. So anything that happens the day before would be recorded today in CEDARS. Good thing doesn't come with a cost. It's dynamic and up-to-date data. We would be able to match with the clinical notes by the written by the clinicians that are not structured data. But the thing is, because of the way that we download the data, it actually takes a lot of time, and it's restricted data collections that we have to do it within one of the to access the intranet and HA. So that answer the first question, whether the data is available. So pretty sure data is available. And then moving on to how complete it is. So speaking of the subject matter, antimicrobial resistance in Hong Kong. Well, now AMR is coined the term, it's a grand pandemic, which it's a WHO refers this as a health emergency, also aligning with the Hong Kong government public health priority. As you see in this slide, I took a screenshot of the strategy and action plan published by the Hong Kong government, where it lays out a action plan to combat AMR. So AMR is quite different from COVID and other pandemics that we recently went through, AMR, it's very likely, it's an evolving problem with a very limited antibiotic pipelines available. So restricting the use, having a appropriate use of antibiotic or antimicrobials is very important. So some researcher, they estimated by 2050, 10 million people would die each year due to AMR. So very scary figure. And to start with some of the research, we wanted to focus on something that's already in place, especially the surveillance that is already in place in Hong Kong. So we noticed we have a carbapenem resistant Enterobacteriaceae, which is one of a group of bacteria that is resistant to carbapenem. It's very last resort antibiotic. So we focus more on the surveillance system that's in place for this group of bacteria. So carbapenem-based producing Enterobacteriaceae or carbapenem-resistant Enterobacteriaceae is one of the antibacterial and antibiotic pairs of critical priority listed in the WHO threat list, which is also shown in this figure. In fact, actually, the top three critical priority bacteria and antibiotic pair are all resistant to carbapenem. So you know that you can gauge that the problem with resistance to carbapenem basically really pushing us to the very last resort potent antibiotic. So CPE is a group of gram-negative bacteria resistant to almost all of the beta-lactams, including penicillins, macrolides, carbapenem, very commonly used antibiotic groups. Carbapenem, one of the very, very last resort antibiotic. There are like more antibiotic available, but we wouldn't want to use the next in line. And then why did we pick CPE? So some background information of the surveillance that's available in Hong Kong. In the public sector, the CPE surveillance is implemented since the end of 2010. So we have more than 10 years of the surveillance that's already been done in Hong Kong, and it's ongoing. So there are some risk factors for all of the patients admitted to the public hospitals managed by the hospital authority by HA has to be screened for colonization of CPE. The first is like the prior travel history, hospitalization history in overseas within 3 months, any admission to ICU or undergone any high-risk treatments or procedures such as dialysis, organ transplant, very invasive operations, and also history of medical ward admission. So all of these patients, when they're admitted to the public hospitals in HA with any of these risk factors, they will have to be screened for CPE colonization. As I mentioned, in the HA data, because we have to, when we collect the data, there are like sensitivity tests, could be genotypic, to sensitivity tests against carbapenem that are routinely performed in the clinical specimens collected. So we actually conclude that we have a pretty comprehensive CPE surveillance data available in Hong Kong. So we check off the next point. We have a pretty complete data. So how credible the data is. So I'm gonna bring you guys to another line of work that my group has been working on. So we're actually commissioned by the Hong Kong government when the COVID-19 vaccine was first rolled out, because it's emergency use, so we have to monitor the safety. And what we did was we put together a program which is called CARE program. That's the COVID-19 vaccine adverse events response and evaluation program, where we utilize the hospital authority data or the electronic health record available in Hong Kong to evaluate the safety of COVID-19 vaccine. So we obtained the data from the Department of Health, the vaccination data from the Department of Health, because the vaccine was available to all Hong Kong citizens for free at least for the first 3 to 4 doses. So we have a very comprehensive and complete record who was administered the vaccine. And then we also have the hospital data from HA, where any of the adverse events serious enough to be hospitalized would be sent directly to the hospitals and hospital authority. So we have a pretty complete picture to monitor the adverse events. So we published quite a lot on the vaccination safety. One of the papers that I wanted to highlight is this paper that we published in 2022, where this is actually the first piece of evidence showing there's Bell's palsy. It's an adverse event of CoronaVac, the inactivated vaccine available in Hong Kong. So something to highlight, because of the it's dynamic, the data that we have in Hong Kong, and the way that we collect it enable us to access the data very soon after the vaccine is available to the public. So we were able to collect 1 million data from 1 million vaccinated individuals within 2.5 months after the vaccine program rolled out. So I would say this is pretty impressive, and it's very, very timely evidence that we support the safety of COVID-19 vaccine. We also published a lot of series of work on the risk of carditis after the Pfizer-BioNTech vaccine, the mRNA vaccine. So it was all of the studies very highly cited, and we also outside of COVID-19 vaccine safety work, we also published a lot on using the electronic health record in Hong Kong and various different subject matters. So I would say data is pretty creditable in terms of the electronic health record, capturing the events. But in the terms of the subject matter where we talked about AMR, we're still not sure. So because of this, I kind of did I would say, groundwork to utilize the electronic health record in AMR research. So as I mentioned, CPE, we have a pretty comprehensive surveillance system in Hong Kong. So I picked CPE as the bacteria that I'm interested in, the AMR bacteria that I'm interested in. And then we did a study to describe the epidemiology of CPE in Hong Kong, examine the risk factors, and then main goal is really to demonstrate the use of electronic health record for to study CPE carriage colonization. So the paper is actually published. So if you're interested, feel free to take a look. So this study, we used the CEDARS data, where we collected data from the HA intranet. Study period spanned across 12 years. And we identified all the patients hospitalized in hospital authority where they receive a carbapenemase genotyping screening test. So that's the test that they usually use in terms of CPE surveillance. To examine the risk factors associated with CPE colonization, we conduct a nested case control series, which is basically comparing people with the at least one CPE positive test in their hospital episode with the people who received the screening test, but with a negative CPE identified. So we compared the patient characteristics, and then we matched them, something to make sure that they are comparable. At the end, we actually identified 8,500, more than 8,500 individuals who received a CPE screening test across the 12 years. Most of them are a genotypic test. We only included the ones, with complete data, and then we were able to identify quite a sizable cohort of cases in control to examine the risk factor. So this is the number of tests and incidents that were identified during the study period. So at the very beginning, the tests given for CPE surveillance was mostly culture tests. But because we included just the genotypic test, the first test that we actually identified is in around the year of 2015. So 8,000 something patients receiving CPE across 4 or 5 years. So it's actually quite a comprehensive surveillance system in Hong Kong. So you see, there is actually a pattern that we see where there's a kind of surge, seasonal patterns. There's a surge usually in summertime from July to September. And then we see that there's actually a gradual increasing trend of CPE identified in. So this subtype of enzyme, NDM, was most common in Hong Kong. Mortality within 28 days, if there is a CPE positive isolate, it's around 26%. In terms of identifying the risk factor, we found that any prior exposure to beta-lactam antibiotic is significant for having CPE colonization. So the conclusion of the study, we show that there's really an increasing number of CPE incidents in Hong Kong, which correlates with some findings in a smaller scale local research in selected hospitals. So that kind of triangulate that the electronic health record, it's pretty similar to what is already published in Hong Kong. NDM, this subtype, is most common in Hong Kong, which is quite different from other countries. Could be something which indicates that CPE epidemiology varies across the regions, highlighting the importance surveillance AMR research has to be done in different regions. It's not just in Asia and then all in Asia, we can assume the patterns epidemiology is the same. We have to do it we have to run the research, we have to conduct the research in the local basis to be locally relevant. Risk factor for CPE colonization show the use of beta-lactam antibiotics being a significant risk factor. So actually we hypothesize that any exposure to beta-lactam antibiotic creates an environment stress that encourage CPE or CRE colonization. So I would say the study is pretty successful, and then we show that the data is quite credible in terms of conducting AMR research. So what's next? We were able to demonstrate the feasibility of leverage electronic health record in AMR research in Hong Kong. So the next step is we can conduct a comprehensive risk profiling to help develop the surveillance system. So it's not just CPE. We can expand it to MRSA, VRE, different AMR bacteria or microbials where we have a comprehensive risk profiling. And with this evidence, we will be able to set a baseline which enable us to detect any potential signals. So we can develop a surveillance system, an automatic surveillance system, which would help us detect any increase in AMR incidents where we will be able to intervene at an early stage. So some pros of using electronic health record enable us to acquire sizable study cohort and give relevant information without substantial amount of time and resources. As we know, AMR investigation with microbiology usually takes collecting samples, a lot of lab work. But if it's something that's routinely done, we can maximize the use in the routinely collected electronic health record. It enables us to enhance the early detection of AMR outbreak, so we can give early intervention. And then eventually we will be able to reduce the healthcare burden associated with AMR. While what we do is we prolong the susceptibility, the time where the antibiotics could be used to treat some essential infections while we're waiting for the new pipelines and new solution where we can continue to combat AMR. So to conclude, can we leverage electronic health records to improve antimicrobial resistance surveillance system in Hong Kong? Definitely yes. So I would like to thank the co-authors of this paper, and thank you. It'd be good to know your perspective. Thank you.
No, thank you so much.
Thank you very much. Thank you.
Thank you. Our next presenter, we're happy to welcome back Dr. Barry Solaiman, because as we know, Dr. Solaiman is from the Hamad bin Khalifa University in Doha. And of course, he's going to speak to us on one of our continuing focal area, AI, and the applications of AI in terms of the deployment of big data analytics as well as in drug discovery.
Thank you so much. First of all, slight apologies for those who were at my last presentation, because the first 2 or 3 slides might be similar, because I'm going to set similar context, but the details will be different to what I presented recently. So focusing then on specifically One Health and legal paradigms in research, there's a few themes that I'd like to bring to your attention and offer a case study of developments in the GCC, particularly with a look at Qatar, UAE, and Saudi Arabia, because I think there's some interesting lessons about what's developing there when it comes to the AI space and regulations. Okay, so first, let me just provide some context. This is just to situate what I'm about to talk about with regard to One Health and the developments. So this is a framework that I presented in another paper that's linked on the slide, which just helps to articulate how we've moved from the path of the development of technology in the space of AI towards law. And so what has happened is that this is a 4-stage process. In the first stage, we've had the development of new technology. AI is not new, it's been around for a long time, but new problems posed by AI, such as its autonomous nature, explainability, and so on. In the second phase of the framework, the response typically has been, from medical law academics at least, to examine existing law and see how can we adapt that law to deal with those new problems. And the answer often is that the law helps us, but it only takes us so far in dealing with those problems. So we need new solutions to deal with those new problems posed by AI. In the meantime, in the third stage has been the development of what I call a soft law stopgap. So that is the development of guidelines and policies around the world to help plug those gaps that the law hasn't been able to fill. And we see, for example, guidelines from the OECD, the EU, the UK, the World Health Organization. There's hundreds of these. And those soft law guidelines then feed into governmental and intergovernmental discussions about the development of new law. So the hard laws coming out of the EU, the Artificial Intelligence Act, the Liability Directive, the Revised Product Liability Directive, and so on. So that is the context and the framework for you to understand what I'm going to present today. And what I am going to present today in large part will be that soft law stopgap, what's being developed in the space of research, because we don't have any laws yet, and what I've been working on in HBKU in Qatar for the last couple of years. But I'll speak a little bit about the hard laws too, the data protection laws, although they have not been developed specifically to deal with the problems with AI. Okay, so that's just context. I'll say a little bit then broadly. I know we've had some themes already discussed about the use of AI in this One Health space, but I'll talk a little bit more broadly, and it might bring in some themes from yesterday that were also discussed that are of relevance through these examples. So it's quite pervasive how AI is being used in health generally. I'll go through a few examples of these that I've listed on the slide. Again, this is all to assist with context too. So AI is being used to detecting disease. So by monitoring patterns in human health data, animal health data, environmental data, collectively, algorithms can identify potential disease hotspots and predict outbreaks before they escalate. If we think, for example, in the human space, we've already seen algorithms that have developed with biocompatible implantable AI platforms that can differentiate between healthy heartbeats and 3 common arrhythmias with an 88% accuracy rate, which consumes less power than pacemakers. If that's just one example of detecting disease. If we think about modeling zoonotic diseases, those that jump from animals to humans, AI-powered predictive modeling can help identify regions and conditions that are at higher risk of zoonotic spillover by analyzing factors such as climate, wildlife behavior, human population density, and it can offer insights into potential disease emergence, enabling preemptive measures to reduce the risk of outbreaks. And we've seen algorithms developed in, for example, Montreal, in the University of Montreal, for predicting interactions between mammals and viruses. An AI model, for example, was developed which required 10,000 hours of computing, 80,000 new potential interactions between viruses and hosts were identified. The researchers selected 20 key viruses worth monitoring and identified hot regions where resources should be focused, such as the Amazon basin in South America and Central Africa. If we think that's another example, if we turn to the environment, AI-equipped sensors and drones can monitor environmental parameters, detect pollution levels, track the movements of endangered species, and this data can inform conservation efforts. So, for example, AI has been used in air pollution monitoring. A drone system was developed by MIT for this purpose to process and integrate data points from a fleet of drones. This collected real-time air quality data and analyzed it in relation to wind and traffic patterns, as well as historic pollution data. This provided a more comprehensive understanding of urban air quality. Pandemic responses is quite an obvious one, as we know recently, with the AI-powered analytics being able to process a lot of information, and AI has played a significant role in almost every aspect of the COVID-19 response, including understanding the virus, accelerating medical research on drugs and treatments, and predicting its evolution. Animal health. So AI-enabled diagnostics can aid veterinarians in diagnosing and treating animals more efficiently, and there have been AI systems developed for veterinarians to, for example, in X-ray radiographs, which provide automated analysis of the X-rays and to aid veterinarians in diagnosing various conditions in animals. So if one just digs a bit, we see the use of AI does pervade quite broadly. If we think about the One Health concept, and there are examples of it, if we look, these are just small ones I'm offering, but there are more. One issue that underlies all of this, and not the only issue, is, of course, data. And there are many aspects we could consider about data, but the theme today is about data. And one that has been interesting to me is seeing the development of cross-border data rules, because that is quite crucial to the development of these AI systems, is the sharing of data across borders and what are the rules in that regard. And I think the GCC countries provide quite an interesting example. Now, again, just to take a step back a bit, I spoke a little bit earlier this week about a book that's coming out next year called AI, Health and the Law that I'm co-editing. And in that book, we look at different jurisdictions around the world and their legal developments for AI in this space. And what's been very interesting to me, which I didn't anticipate, was that countries like Saudi and the UAE have taken a lead in developing governance structures in this space. So the UAE, as far as I can tell, is the first country to have binding guidelines for the use of AI in hospitals and clinics broadly. Saudi Arabia has medical device regulations, which are, I believe, binding. And Qatar was the first country in the Middle East to develop data protection laws, which are modeled on the GDPR. So these countries are very much at the forefront and they're eager to develop in this space. So when one looks at what they're doing, there's some interesting insights. And that's why I'm bringing those examples forward, not simply the obvious countries that we've also examined in the book, like or jurisdictions like the EU, the US, China, and so on. So in Qatar, we see AI being used quite widely. Widely may be overstating a bit, but it is being used in hospitals and in research, particularly in the area of cancer research. So identifying cancer risks and being able to create specialized treatment plans for cancer patients. There's also been AI, they've implemented AI powered devices for the use with electronic health records, wearables, genomics, medical imaging, lifestyle intervention for diabetes and more. The Ministry of Health in the UAE is actively deploying AI in the healthcare sector for medical fitness examinations for new residents to detect communicable diseases. It's also being used in research quite broadly. It's being used in hospital administration to manage patient flow, monitor patients with chronic diseases, predict the onset of illness in the community. In Saudi, they see the use of AI as a necessity. Systems are being used in the clinical context in quite widely in the King Faisal Specialist Hospital and Research Center to undertake descriptive and predictive analytics to improve the management and flow volume of patients, perform thousands of interventions in how the systems operate and so on to manage disease flow. So one area then that I saw a gap in Qatar was in the need for guidelines in research. So there are researchers in this region who are using AI to develop various systems for health applications, and there are no rules. And it's interesting when speaking to the local researchers just informally, almost the frustration at the idea of having rules, and this is a theme. And so when you have conversations with them and say, well, what is it that you're actually doing, and why do you think we might need rules? They see very much the rules as an impediment to innovation. But those guardrails are needed. They're absolutely needed because it's being used in the health space, these applications. So for the last about 3 years now, I was awarded a research grant at HBKU to develop this framework, a soft law framework, let's say, for research that's conducted in the country. We want that to be a model for the rest of the Middle East. So whereas the UAE has developed binding rules on the use of AI in clinical practice in hospitals, and they've taken a lead there, whereas Saudi Arabia, I think, have taken a lead in the medical device regulation space, I'm hoping that we in Qatar have taken a lead in the medical research space and the guidelines there. And now we're starting to see those conversations between each other through various committees at through the Ministry of Public Health in Qatar. So the Ministry of Public Health are also involved in this grant, and I've been in conversation with them from the beginning. So they have been intimately involved in the process that's been undertaken to develop these guidelines. And my co-PIs are all drawn from different academic disciplines. So one of my PIs, colleagues, Muhammad Ghali, he's very well known in bioethics circles for his expertise in Islamic bioethics, because when we developed guidelines, one of the things we identified was, well, they need to be region specific, not just generic. And what are the considerations we need to think about in the region? So, and we have others drawn from different departments, science and engineering, College of Health, and so on. So it's quite broad. We've got the head of the Qatar Genome Program, which is a top genome program globally, is also a part of the grad, Syed Ismail. So we've got a great team, and we've built out these guidelines. they are now in a very later stages of testing. So I can't show them all, but I'll show snippets and discuss bits of it. Where we are now is we've got this 44-page document, a very detailed set of guidelines, where we hope that researchers will, when they are developing AI systems in the country, they will follow these guidelines. And we're creating a website where they can submit or they can complete a form in conjunction with the guidelines, and then that can be assessed by a committee, and that committee can give feedback. It's all informal right now. We're just creating these mechanisms and these details there so that if governmental entities want to then use that, like the Ministry of Health, and formalize it or take it, have further discussions in the years to come, they have it there. It's for them to decide. So we have principles underlying the guidelines, and those are the obvious ones that arise in most guidelines. But what we try to do is at least to think about, well, how are these different in the region? What do we care about? So, for example, on the principle of fairness, in the Middle East, there's particular concern about the underrepresentation of regional data used to train algorithms that may be used on those populations in the Middle East. Literature often notes how biases in the data reflect deep and hidden imbalances in institutional infrastructures and social power relations. This applies not only to citizens of Middle Eastern countries, but to subpopulation residents, such as migrant workers in the country. So the challenge that the region has is if they are using off-the-shelf algorithms that are developed in Europe or the US, they're trained for very different populations to whom they're applied on in the Middle East. And we're already seeing those problems even across states in the US, where systems trained on data in one state are applied on populations in other states, and they're not very accurate. So to take that cross-border to other countries is problematic. So that's why it's important to encourage research locally, but then that needs guidelines so that the processes are at least robust. And it also requires important rules around considerations around data, which I'll come to in a moment. So we divided the guidelines into 3 stages. That is the development stage of an algorithm. Second is the external validation, how it should be externally validated. And third, what the researchers should do upon deployment, if it is deployed. This is the overarching sort of structure of the guidelines. So we go into quite a lot of detail. So we're looking for transparency. What are the details of the entity in the research project? How did they select their model? What is the intended use of their algorithmic model? What was trained? How did they train the model? What were the data and ethics factors they considered when training the model? How has it been evaluated? How have they externally validated it? Did they go to any external entity and seek validation for the model that they've developed? If so, who? And what was the result of that? Once deployed, and once the algorithm's in use, have they considered matters of explainability and interpretability, contestability? What about accountability if something goes wrong? How are they monitoring it on the ground? So this is the overarching sort of framework for it. And it's been, again, developed in close conjunction with actual AI developers who are following these processes and have informed us through numerous drafts and numerous committee meetings. What you suggested doesn't reflect reality. This is not quite how it is. This is really how we work on the ground. And this is, what you should incorporate into the guidelines. So here's an example of, for example, just a small part, 3.1.4.2. I know it's a bit small, I'm sorry, but I tried to squeeze it in. This is a sort of instruction that we would ask from the researchers. So state the method used to determine which data was incorporated into the model. So we want them to set out their methods. Confirm what factors are being examined by the AI system and justify those factors. Factors include, but are not limited to, data on gender, race, health, culture, demographic, phenotype. Disclose any biases that the model could have possibly encoded, include the following: data sensitivity of the model, whether the model is intended to be used to provide information about human health, consideration for majority or minority groups, biases caused by underrepresentation. We asked them to identify potential risks and harms in the model to any individuals, groups, or demographics. We asked them to determine whether alternatives to sensitive or identifiable data can be used and outline any steps taken to minimize data biases concerning citizenship, residency, religion, ethnicity, age, race, gender, and other traits relevant to Qatar and the Arab region that may come up in their research. And to state transparently any limitations of the model if biases cannot be removed. So this is an example of the detail. Okay, these aren't generic guidelines, I would say. This is, please spell out these aspects of your research. And this is throughout the guidelines. This is the level of detail that we have set out. And maybe it's too much, some researchers might think, and fair enough. This is just, this is something that we're trying to put out there and see once it's completed, perhaps in the next 6 months, this will become a public document and it's in full. We can get more feedback and others can take a look at it and give more feedback. The whole point is really to spur a conversation and to get people thinking, get something out there, at least. You know, we can disagree about the specifics. So that's just a snapshot of that. I also want to talk then a little bit about data and how it's raised interesting issues in the region too. Okay, so there are data protection laws across the 3 jurisdictions, and they're pretty similar in certain ways to the GDPR. Now, as I mentioned, Qatar was the first country in the Middle East to develop a data protection law, which was modeled on the GDPR. And in all of the laws across the 3 countries, they have this similar provisions on processing data of a special nature, which includes health data, that interesting category that is in the GDPR. And they have provisions on data controllers and consent and processing in medicine. And I'm going to come to the cross-border point in a moment. But invariably, when one digs into the laws, it's specifically in Qatar, I haven't done a deep dive into UAE and Saudi, but in Qatar, there are exceptions for using health data. And if they're used for clinical purposes and so on, it's actually, I think, quite easy to comply with the data protection law. It doesn't require much more than saying you obtained consent from the individual, I would say. So there's not really a prohibition on using health data. And I think that would probably extend to researchers in health trying to develop AI algorithms as long as they're obtaining consent. And some other rules are complied with, but it seems pretty flexible. But that's not the issue I want to talk about. I'm more interested at the moment in the cross-border questions. So they all take quite different approaches. Now, this cross-border data issue is important, as I said, because if you're producing data in these countries, what are the rules about where that data then goes if we're seeking to develop algorithms that are trained on these specific populations? And so Qatar has actually got the most liberal approach. In Qatar, the data transfers across borders are, well, to put in the words of the law, it forbids a controller, data controller, from taking any decision or measure that may limit the cross-border data flow, unless the processing of such data is in breach of the law or where such processing may cause serious damage to the personal data or to the individual's privacy. It's like a default position of forbidding limits on cross-border data transfer is interesting. It's there are exceptions in specific spaces where there are regulations, such as in finance, where there are extra layers concerning data transfers. But the core position of the law is let data flow, let it go out, and that sits quite in opposite to the UAE. So the UAE has an ICT law that has strict requirements on data localization, so that health data may only be stored, processed, and processed, generated, or transferred outside the UAE with a specific resolution permitted by the ministry. And it doesn't appear that any such resolution has been granted so far by the ministry. the ministry did issue a new resolution in 2021, which sought to clarify cases where health data can be transferred outside the UAE, such as for scientific research, which complies with UAE law. But the law is still being criticized for being contentious, undesirable, because a data transfer must fall squarely within one of these exceptions its new resolution has created. So UAE is quite the opposite. You are a researcher in the UAE, it's very hard to transfer data for the purposes of research. Saudi has taken more of a middle ground. It was initially quite restrictive, like the UAE, on cross-border data transfers, but it updated its law this year in 2023 using data adequacy language similar to the GDPR, mandating that data can be transferred only to jurisdictions with equal or higher levels of data protection. So that's the position that Saudi has taken. So this is just broadly thinking about how we see these different developments occurring in these three jurisdictions and the effect it might have on AI research, which they're really trying to encourage. I haven't even mentioned that they have their own designated AI ministries. So what this will mean then for health research will be interesting as we move forward. And I think it's going to be crucial to analyze how these data laws are going to have to develop to account for the research in this area for these AI systems. Oh, and those are the, I should have moved to that slide earlier. Okay, so I'll stop there. Thank you all for listening. I hope it's some food for thought at least. And feel free to connect if you want to ask anything or continue the conversation. So thank you so much.
Right.
Yeah,
Thank you
yeah.
so much. Yeah, thanks again, Barry.
Thank
If you
you.
join me again, thank you, Barry Solaiman. Thank you. So our final presenter before our intermission is Professor Yali Cong. So she comes to us from Peking University. She has got lots of experience, you see from her CV, working in ethical governance, with, of course, one of the leading institutions on the mainland. Yali, you're welcome to present in either English or Mandarin, depending on your preference.
I practice English. Thank you. Thank you. My honor to be here for invitation and thanks for the funding for the activities, and I can meet some old friends and know some new friends. Yeah. Actually, this topic has I didn't to present this topic before, but one of my master student and I involve a smaller project. This project is funded by Oxford and Johns Hopkins. The connection to apply the funding from Wellcome Trust, and this called, I think, Global Infection Disease Access Collaboration. And I'm a consult of this project, so I have opportunity to apply. So it's very seed funding. But we not focus on the digital tool, but focus on the patient engagement. Yesterday, Khalifa mentioned we do more about patient education. So that's the background of this. And some materials is prepared by Luna. That's my master student. Yeah. Okay. And the idea I would like to share with you all. The first one is how China situation of the AMR in the whole world, and is combined on AMR, what's the current progress. And but for prepare for today's meeting, I find because I think very carefully about the sub-theme of you mentioned the barriers to the effective use of digital tools in addressing AMR concerns. So to combine my small project before and the new thinking and the new literature collection, the reading to focus on the subset of the second one, and to form today's presentation. But I find the previous study and the new thinking of the digital tool focus on AMR concerns, they share some similar ethical tensions. So that's the most important message I would like to take today for the last part of my presentation about some ethical tensions, the different relationships, and where responsibility come from, and how we think in the futures. So, but we can not only focus on the AI, the digital tool, some traditional ways, approach for the AMR type, combat AMR still have its important role. So that's the main ideas. And yesterday we mentioned the One Health background. That's true. And we know not only the human domain, but the animal health and the environmental. Even I cannot very well how mental health related to how we do that. But I'm not sure. But the humans and animals, yesterday I can. So thanks for the previous presenters, and I really learned a lot from your presentation. And that's true. We need the surveillance strategy, but I also agree that the existing local and global AMR surveillance systems lack an integrated One Health approach, which means the synchronized the human, animal, and environmental resistance data in the same surveillance networks are missing. So I think maybe we have not yet to do a very good study in the global way, but it is the current situation we need to think. But today I will focus domain of human and antibiotics, which I mentioned before my small project. But I also would like to combine the global perspective and the local perspective from China that I would like to share with you. Actually, it's not a good phenomenon, but it's true. China contributes a lot of AMR. I think it's the top one, maybe. But I also read some literature, some others, especially the the area in Africa, they also contribute a lot. But still, China, I think, in the top two at least. So the situation, I think, it cannot only to criticize, but because China is a huge population, but we still have our problems, our not healthy role, behaviors to take drugs, and also our healthcare system in the previous, I think the last 2 decades, and still the doctor's prescriptions have influenced by economics and the drug companies and many things related to that. Especially, I think China's resident people, including myself, including my parents, including many of my friends, they would like to take drugs by themselves. They think they are doctors. They think they know medicines, especially they know the traditional Chinese medicine. So they prefer to prescribe for themselves. And then they go to the drug store to buy the drugs, and then they take for themselves. And then also they recommend the drugs for other friends. And then they store the drugs for themselves and for the future use. So many, that's wrong behaviors, but I think very common, at least within the last 2 decades. But the ways we have changed a lot nowadays. So that is one phenomenon we need to think. So that's a little background about China, why contribute a lot of the AMR today. So that is, and according to the WHO's action plan, and it requires every nation members to issue their national action plan. China is very actively to follow the requirement. China government is really actively to follow this, and because the WHO still has a very important role, and the first national plan already finished, and the new national plan already started from 2022, and the 5 years. And our small project aims to provide some new recommendations for the new national action plan. We want to find some new phenomena we need to think maybe missed by the second national action plan. So we have some materials to show how much progress China government has achieved in the last decade. And it's true, China government has made a much effort, not only to meet our health issues, so many regulations to require how the hospital need to the antibiotics management. And every big hospital, they set up a separate office to do these things. Under the physician's prescription, they will make a conclusion in the end of the month who prescribe most, what's the reason, whether it's right according to the guidelines. So it's truly we have made a huge progress. But still, China's population is there. We have many things need to do later. And still, I think China's AMR situation is still very serious. And so that is, and also I think physicians have been trained for a lot. Their prescription behavior, habit have changed some. So that's our progress and the current situation. But I think my project with my student and I involved, we focus on the patient education and public engagement. Because why we focus? Because it's really a seed funding. We can only focus very focused one. So we think no matter how many regulations issued by the government, how the office worked well in the hospital, still I think many final step is on the shoulder on the people themselves. That's why we focus on the patient assembly and the public. So, but we found the Chinese government's national action plan is very focused, addressed on the patient education. And the patient education is our focus. We not focus on the public engagement that yesterday Khalifa mentioned, but we regard patient education is one part of the public engagement, because we in our culture, we really not mature to a big, widened scale of the public engagement, but we are more easy and habit to be educated by the hospital. So that is one way we currently, but how the public engagement can play a role in the future, I think China should to do this in the later. And also I think we need to find some other barriers to address our AMR situation in China. So we focus on not only public, but we also attention on the others. So to answer the sub-theme of this conference about the barriers of the digital tool for MRI combined. And we have read some the materials, and this we didn't notice before. And we found within the couple of years recently, AI has been successfully used in various fields. And some papers have showed the AI has played a so important role and has played a very important progress to reduce the antibiotics use. So that's true for the digital use. But I think not only the AI tools can play important role, but from the literature review or reading, I find some concerns related to the digital tool. Just like our first speaker today, this morning you mentioned. So digital tool is good, but it's not so good sometimes. It has some problems. So I also find from the literatures, especially they called the antibiotics or antimicrobials steward or antimicrobial steward shape program. And it's mentioned the role of the digital tools, how played and how been expected to play as the following aims. The first one, data collection, and they have used collect many useful informations. And the second one, the data synthesis and the calculation. They use a comprehensive analysis of the antibiotics drug use information from the multiple sources. And the third one, the data analysis and the suggestion also do a good job. And the final one is assisted regulation and intervention how being used in different countries. But even it has played important roles, and I can you can find from some literature I list here, they have reached some positive outcomes, but some other concern I would like to share with you as follows. And I think our responsibility should become from these concerns. So they change decision-making model, that is a digital tool. They have formed the AI tool. It has formed the decision-making, the models to help the physicians, and some hospitals have implemented this role, and they tend to this role, use this model, and they tend to like this model to replace the physician's prescription habit. So that's on the one hand, this model have played an important role, but the other hand, we can think this has its own rationality. So, but with people, we should do this to reduce or we can to combat AMR, to serve the humanity as a whole and the country. And the duty comes from this, our responsibility comes from this duty. But this MIS or ASP digital tool is a kind of alternative integrated decision model. That means they take part of decision-making power away from individual clinicians. That means the hospital use this tool to place, at least partially, to replace the prescription by the individual physicians. They use this tool to replace the physician's work. I think that is the problem. We have to think that is this power have been to use to reach aim for a reduction of the antibiotic use, but whether it is have something we need to concern from this topic, that is two concerns. The first one is, just I mentioned, it take the decision-making power of drug use away from individual doctors. The other is that evaluation criteria for effectiveness test of these digital tools are usually to reduction in the number of the antibiotics drug use. That means reduction is the aim itself. And the AMR combating, AMR tackle, we need to focus on our AMR antibiotics abuse, not only focus on the reduction, because sometimes use in the developing countries, because they have their poor health situation, they not, if we only focus reduction of the antibiotics use is a risk for the population health. So that's, I think I would like to propose to share with you, and the literature is in the below. And also we have to back to, because it's a antibiotics stewardship program, and now they developed the digital tool. So we have to back to the concept of steward. And the stewardship from literature, at first it occurred in the environmental health. environmental ethics. That means the people, we people, still would represent ideally humanity is steward over the earth, but we to represent the God to steward the earth, but we cannot to steward in other way as we humans. We cannot do as we want to do. So my thinking, but I'm not sure whether it has some problems. By my thinking perception is this words. In the clinical setting, how to understanding steward this the meaning. So in my understanding, because in the clinical setting, the physicians, his first primary responsibility is to his patient in front of him. It's not the other invisible population in the future. So if my assumption is true, that means the stewardship, that means for the clinical settings, the physicians, they have to think properly cannot do in balanced way. They have to focus on the both individual patients and the future population. But your primary responsibility is your patient in front of you, not others. So that is, I think, is an ethical tension I would like to propose. I also will mention later. So such tools seems to suspected of over-invading patient individual interest. Individual clinicians are originally responsible for individual patients, but when their decision-making rights are divided, it's worth noting that a proportion of this division of decision-making rights is very vague. Different digital tools can divide the decision-making, but it has raised some problem. So that using such digital tool can reduce the drug use. Reduction of antibacterial drug use as the most important indicator. But if we understand the steward, we understand the rational use, we think sometimes this tool is a little bit overkiting. So what this overcorrection brings is that no one speaks up for the rights of independence. So that's it's a danger for the current population. So that means the patient are likely to unaware of that because the patient trusts the physicians in front of him. But if the physicians, they are replace the use of digital tool for the prescription, but the patient unaware of this, that means their decision power about the medication does not entirely belong to the individual doctors. And it's the doctors they trust, not the digital tool they trust. And the patients, sometimes they are not informed aware about this changing of the situation. So the digitalization brings necessity of the unified standards. That means that a very complex medical medication situation already be too simplified. Even it has some good outcomes currently. Another issue is that in the alternative integrated decision-making model is what are the effective indicators that can properly represent interests of all the parties, not only the future, but all the parties involved. I think is one we need to consider. So, so even I mentioned, previously, I mentioned China context, but I would like to base this is on the global context. And the digital tool is something like it's one feet, it's one ruler. We all know the one ruler cannot face everywhere. It can only face some specific context. But the countries saw the barriers. China and many other developing countries, their health, due to their poor sanitary conditions, during their not the well developed the device to test the bacteria, so they have to, because they don't have much time to wait the testing. So they have to prescribe or take drugs in advance to prevent possible, adverse outcome in the future. So there's many various backgrounds. So we cannot only use a one fit, only one digital tool, one decision making model to combat AMR. So that means we have to think some other developing countries. And these two materials below, they mentioned something India and some South African countries. If we use this digital tool, it will bring very dangerous and risk for the population health. So that's already a big concern by some scholars. Some other tensions I would like to make conclusion here is who is the priority of the population of global health? So because AMR ethics is so important because we live in the globally, and there's so many countries contributed to this, and UK has issued a very good report. I think is in 2014. That means in the 2049, like around 2050, if we cannot combat AMR well, there's a huge the danger to the global health. And also, I think that because the low-income countries and high-income countries, and they face different challenges. So how we need to combat AMR collectively. So the high-income countries, they have their different background. And the low-income countries, they have their historical reasons. They have to think this more comprehensively. It cannot have a similar models to combat. So that is we need to think whether the digital tool how to adjust in the future. And also today also mentioned, as the first speaker mentioned, in the new drugs developing countries, they don't have much ability to develop some new drugs, and they don't have the much economic capacity to do this. So still, I think we have to work together to think what's the much better working mechanism. So what's the aim of AMR tackle? I think complexity we have to take into consideration. Not only the one tool can fit all, that's not the answer. So if it's reduce the use, or we to avoid abuse, that is, I think, right answer. Rational use is the right answer. That's the other tools is not right. So the current digital tool is only focused on reduction. That is, they can do something good, but they still leave many other things left to concern. So whose responsibility and whose interest we have to think from this. So that's I mentioned in the very beginning, this small ground, and I to prepare for today's presentation to do some literature review, and I found some similar ethical tensions. That is where responsibility and whose interest we need to think in the future. The nature of antibiotic use is a clinical setting, but the short term is clinical setting, but the long term is public health and the global health setting. So we need to something to dynamic consideration, not only fixed on the current one. And the result MR might not due to the fault of the patient in front of you. They have many historical reasons. So we cannot compromise their interest and to only for the futures. So the digital tool is important, is very valuable, but we need to consider the local context. That means the digital tools, we have different kinds, different levels, and we need to think together how to combine this, the new considerations, and also need to consider the boundary of digital tool to combating the AMR. The final one is not only a digital tool, but a non-digital tool still need to go in parallel, because some traditional approach to combat AMR is now and still have its important space to do. And another way is because I focus on the patient education and we found that even in the first national action plan, we have do a good job, but still something missing because they have regulation to regulate the people's to go buy a drug by themselves, and they already require them to take the prescription from doctors. But the new phenomenon that is online drug buying, the online drug purchase is not, I think it's is a very big hole because the online drug, sometimes they don't require you have the drug physician prescription. Even if you require this, and online they will provide this prescription. They have the physicians online, even you cannot see them. So I think that is that's why the public educations how the proper behavior to take drugs is still to another way. We need to combat the AMR, at least in China's situation. So this is our reference, and thank you for attention. And any suggestion, I'm very happy to answer. Thank you.
Okay, I'm afraid we're at time. Thank you so much again, Professor Tung, for these wonderful
My
ideas.
pleasure. Thank you.
So we have a short break and then we'll have to reconvene with our final set of 3 presentations. A bit of change to the schedule. I'm going to invite Dr. Tu Li to present after the intermission. So he's going to speak with us on an important development on mainland China, and I think it'll be a good opportunity to link up with what Professor Chong has discussed with us. Perhaps also to pick up on some of the discussion points raised yesterday. So I'm particularly keen on this notion that Professor Chong mentioned in terms of stewardship. There's a lot of references to that, and I do wonder how it connects with what Mike spoke to us initially about social licensing, because in terms of the moral imperatives, they have different foundations and justifications. So I'm not sure which exactly is most suited in thinking about managing the use of antimicrobials and related data. So that's one element. And then we'll hear from Jerry coming to us from NUS. So, and in the interest of time, I thought I will then round up with Carl in terms of our presentation. I'll draw on a number of points that all our presenters have raised as best as I can, and then to see if we can chart the next phase of this project if there's sufficient interest. I do hope that there will be continuing conversations, given that quite a few of the presentations that we've heard, they're essentially work in progress. So I presume in the months and years ahead, there will be developments. So, so with this, let's have a short break and then we'll reconvene in about 10 minutes. Thanks very much. Okay, everyone, we are about to resume our final segment of the conference. So, I may invite everyone to return to your seats. Okay. Delighted to invite back to Hong Kong a very close colleague of ours, Professor Tu Li. Welcome, Professor Tu. He's going to speak with us on new legislation that has been introduced on mainland China. I think it is consistent with developments that we've seen in relation to the Convention on Biological Diversity and the Nagoya Protocol, something that we'll touch on a bit later on. But with this, welcome, Professor Tu, over to you.
Thank you, Kelvin, for your kind invitation, and really happy to join this forum. Although my research focus is not on AMR, but most of my research projects are related to genomic research and associated legal and ethical issues. So today I was requested by Kelvin to explore some of the basic knowledge about the regulation of use and collecting and using of Chinese human genetic resources. And I would like to also share with you that one of my recent projects exploring the public's perceptions about disclosure of Chinese human gene sequencing information. So the first part would be very introductive. So anything related to the collection and use of Chinese human genetic information goes to these following laws and regulations. And so on the top of it is the biosecurity law of PRC, entered into effect in 2021. And the other very related law is the Personal Information Protection Law of the PRC 2021. So these two laws are established and passed by Standing Committee of the National People's Congress. So they're on the highest level based on the legal effect in the Chinese legal systems. But you've seen that these laws are very new. It's just 2 years ago. And under that, there's a very direct regulation established by the State Council of the PRC. This is the regulation of PRC on the Administration of Human Genetic Resources 2019. Still, this is quite new. This is an update from the previous version, which was established in 1998. And under that, there are two recently established and issued administrative measures developed by the Ministry of Science and Technology. So there are the detailed rules for the implementation of the regulation on the administration of human genetic resources, and also the notice of Ministry of Science and Technology on updating the service guidelines of filings and the prior reporting scope and the procedures for administrative licensing matters of human genetic resources. So these are the very recent two regulations, I would say, administrative rules established by the State Council, by the Ministry of Science and Technologies. So these rules governs anything related to the collection, preservation, utilization, external provision, and also transnational cross-border data transfer and of human genetic information. And one thing I wanted to highlight is that according to the direct, the regulation of the Administration of Human Genetic Resources 2019, human genetic resources includes human genetic samples, the materials, and also the data or the data generated based on the human genetic resources. Therefore, genetic testing results or the data and also the interpretation of the data belongs to the human genetic resources. And there are other laws relevant in our context, and especially in terms of the enter or leave China of the human tissues, biological products, and the blood and its products. So if you, for example, the researchers carry this kind of sample, wanted to leave China, probably you must follow the rules governed by, for example, here the Frontier Health and Quarantine Law of the PRC, which was amended in 2018. This is also the law is established and passed by Standing Committee of the National Congress, and also need to follow the detailed rules of the implementation of the Frontier Health and the Quarantine Law of PRC 2019. This is established by the State Council of the PRC, and also in 2018, there's an announcement of the General Administration of Customs and Ministry of Science and Technologies about implementing the online inspection of the export permit for human genetic materials. So this is dealing mainly about the export and import the bio samples. So this is not my focus for our next slides. I will highlight some important information from the laws that governing the collection and preserving and also utilization of Chinese human genetic resources. So in terms of the collection of the human genetic resources or put in data, the Article 11 and Article 12 of the regulation of PRC on the administration of human genetic resources 2019 clearly state that if we wanted to collect the person's human genomic materials or data, then you need to have you need to ask informed consent. And this must be in the written consent. And the genetic resources providers shall be informed of the information in a comprehensive, complete, true, and accurate manner. No information shall be concealed, and providers shall not be misled or deceived. And there's special requirement for the collection of China's human genetic resources of important genetic families and specific regions, or the collection of human genetic resources of the types and quantities prescribed by the Ministry of Science and Technologies. So if you want to collect this kind of data, then you must ask approval from the Ministry of Science and Technologies. And these, I just listed the requirements here, and you've seen one of the requirement is to have the approval from the ethical review. For the preservation of the Chinese human genomic data and the resources, so Article 13 and Article 16 already established the kind of encouragement from the Chinese government that scientific research institutes and institutes of higher learning and medical institutions and enterprises are encouraged to preserve human genetic resources according to their own conditions and their interests. And also, China encouraged to establish national basic platforms and the databases of the Chinese human genetic information. And if it is national basic platform, according to the regulation, that it shall be open to relevant scientific research institutions, institutions of higher learning, and medical institutions, enterprises. However, to become the kind of basic platform that collecting the Chinese human genomic resources and provide the services, they must satisfy the following requirements and should be evaluated by the Ministry of Science and Technologies. And among these conditions, ethical review is also the kind of request. So in terms of the utilization of Chinese human genetics resources, the research and development activities using human genetic resources and industrialization of the results shall be supported according to the Article 18 of the regulation. And also, the states encourages international collaborations using Chinese human genetic resources. However, one of the point here is if a foreign organization or an institution formed or actually controlled by the foreign organization or individual, we call this the foreign entity. If the foreign entities needs to use the Chinese human genetic resources for carrying out scientific research, it must seek the Chinese collaborators. And these two entities, parties, needs to file the approval and file the documents and get approval from the Ministry of Science and Technologies. So one of the conditions also when evaluating this kind of application is past the ethical review of the country or where either party to collaboration is located, which means if the Chinese collaborator, if the US based entities wanted to collaborate with the Chinese research teams, then such kind of collaboration needs to be evaluated by both the two countries' ethical review committees. And also, in case of these kind of international collaborations, according to the Article 24 of the regulation, that such kind of collaboration should be participated by two parties. And it shall be guaranteed that the Chinese entity, the Chinese party and its researchers essentially participate in research in the entire process of cooperation, and all the records and data information in research process shall be completely open to Chinese entity, and a backup shall be provided to the Chinese entity. So this is the requirement that to guarantee that the Chinese entities be involved and substantially, not like procedurally, and substantially in the research, be getting all the data generated from the research. For the external provision, so here this is about to make the transportation or mail the materials of Chinese human genetic resources out of China for the purpose of conducting scientific research through international cooperation. There is a requirement for an application of such kind of data transfer. And this should be approved, evaluated and approved by the Ministry of Science and Technologies. And when the provision and opening for use of this information on genetic resources, human genetic resources to foreign entities may affect China's public health, national security, and public interest, it shall pass the security review organized by the Ministry of Science and Technologies. And these give some, confusions or uncertainties in practice that actually the research teams do not know whether such kind of opening to the foreign entities may impact the national securities or public health interest. Therefore, they still needs to file this kind of applications and ask for approval from the Ministry of Science and Technology. So there are some of the confusions and uncertainties here, and also raises a lot of debates in scientific research communities. Therefore, the security review is regulated in Article 37 in these very recently established detailed rules for the implementation of the regulation on the administration of human genetic resources. And also here that the 2019 regulation highlights the importance of consent to obtaining consent from the human genetic resources providers. If this type of information is open to or is shared with the foreign entities, that it shall notify individuals about the information that relates to the overseas recipient's name and the contact information, the purpose and the methods of processing, and the categories of personal information, the methods and procedures for individuals' exercise of the rights provided in this regulation. So this is back in 2019. So in 2021, China established its first ever in history the personal information protection law. So if the data has been, and also according to this law, genetic information, including health information, has been regarded as sensitive data, which needs more protections. And according to this law, if the data to be transferred from China to other countries, that the data processor or controller shall modify individuals and obtain individuals' separate consent. So this is very specific and also high-level requirements for the data processor, and in the context of research, that is research teams. And also in the measures for the security assessment of outbound data transfer 2022, it established that under certain kind of circumstances, to provide such data to foreign entities outside overseas, it must gain an approval from the National Cyberspace Administration Office. And this office will conduct the assessment, security assessment. So some of the conditions, for example, here, the data processor provides important data abroad. So what is important data? Very likely the genomic data can be located in this category. So which means that if the research team wanted to provide genomic data, Chinese human genetic information to the foreign entities, it need to be evaluated by the Ministry of Science and Technologies, and then it also be evaluated to do the security assessment by the National Cyberspace Administration Office. So to summarize the current practice, the laws and the practice about the regulation of Chinese human genetics, we've seen that, first of all, the government encourages international collaborations using Chinese human genetic resources. So this is not prohibited, this is actually encouraged. And also it encourages research and development using the human genomic or genetic resources. Informed consent is actually required for obtaining human genomic resources, and also the personal data if you wanted to collect, use, and transfer the data to another country. Ethical reviews has been required for collecting, reserving, and utilizing human genomic information and the data, and also required for the personal data transfer in the context of international collaboration. Security review is required under certain conditions for cross-border data transfers. And finally, is the foreign entities alone are not allowed to use Chinese human genetic resources to conduct scientific research activities. They need to find a collaborator in China. So my team has explored these issues, and we just published several articles on this about the using of Chinese human genomic data. In particular, what are the legal barriers towards the cross-border transfer of Chinese genomic data. And we found some challenges that we're facing with currently. So we've seen that these laws are quite new. So in the past, this is all the legal and regulatory issues actually were located in the gray zone. I didn't mention in the beginning that in 2000, I think it's 1997 around. So there's a kind of famous cases that I think some epidemiologists from Harvard universities came to the village in Anhui province and collecting the blood of the local residents. I think it's around 1,200 the samples and took them back to the US. And these kind of events just raised a lot of criticisms in the public during that time. So right after that event, it is the regulation of Chinese human genetic resources established. So the 2029 is the updated version on that. And also we have the biosecurity laws, have the personal information protection laws. So currently that human genomic data or resources actually are governed by a multi-layer legal regimes, and it's complex. And several administrative agencies are responsible for accessing and overseeing the human genomic data transfer activities. So this has raised a lot of compliance duties for international collaboration research teams. And also we've seen that informed consent has been highlighted for the procedure of data transfers or even just the data collections and the usage. And also specific informed consent has been established in our personal information protection laws. And these really triggers some conflicts about with the nature of the data-driven biomedical research, because for many this type of genomic research, that the research teams cannot expect the future use of the data. So it is very difficult to make informed consent to the participants. And so far, the governments haven't established any clear guidelines to deal with this. And also AI will trigger another issue, the generative AI, because the model itself can source out the databases and get the data. So these may trigger issues here. And ethical reviews has been increasingly requested in the recent laws. The ethical reviews, these really kind of, in practice, it triggers some uncertainties and the challenges, especially for the data-driven or AI-assisted medical research. As my colleague, Jiping, just mentioned yesterday, and also she mentioned these to me several times, that during the practice, sometimes it's very challenging for them to evaluate the use of data, especially for those data that's been collected before these regulations established. And also, it is very difficult for them to give really scientific review, this in terms of the risk assessment, that how to use this data that can make sure it is compliant with the law. So it's very difficult. And so far, there's no clear guidelines from the government guiding that how to carry out these kind of ethical reviews. And also, we've seen these laws really increase the burdens for the cross-border flow of human genomic data. And the main purpose for this is to protect the national biological and the data security. This is the purpose. However, this kind of robust control is in another way, it's conflict with the purpose or the nature of genomic research, right? So for most of the genomic research, they require the diversity of the data sample that fit in the model, especially from the different nations. But here that the robust control over the cross-border flow of the human genomic data may raise the legal challenges, the legal barriers for such kind of collaboration. So next, I wanted to share with you some one of my recent research, and this is done by our team, because this is also another very interesting social event happened this year in June. So this is then actually the scientific paper published in the middle of June this year. That several genomic scholars announced that their success in publishing in Nature the first pan-genome references of 58 samples of 36 Chinese ethnic groups. They highlight the importance for this project is because it is the first time that these entire projects done by the Chinese research team. But this very quickly raised the heat debated in general public relating to why you disclose this information to the world. So very interesting. Then we wanted to evaluate that how the general public, by using social media, the methods, to evaluate their attitudes towards such kind of disclosure of the Chinese human gene sequencing data. We use Weibo. This is the version of Twitter in China, most widely used social media platform as a search engine, used in search keywords, including the official Chinese translation of the paper title, names of the corresponding authors, and their academic affiliations. The search period is from June 14th, 2003. The date of the research paper was published online to 21st August 2033. So the final data after cleansing and remove the irrelevant microblogs, we have 304 microblogs and that confirm that established as our data set for this research. And then we examine the following questions, including what is the identity of the Weibo users? What is the attitude showing in the post towards the publication? If it's a positive post, what are the reasons? If negative, what are the reasons? And also about the risk associated with the public disclosure of genetic sequencing mentioned in the post. What are the benefits? And importantly, we wanted to see or evaluate the Weibo users, their legal knowledge or their knowledge to the regulatory issues towards the human and the Chinese human genetic information. So we designed some questions like, does the post mention regulations on genetic data sharing, or does the poster mention that the researchers should be held liable? So this is the preliminary results. So I hope you don't take picture because this is not the finalized results. So here, very interesting, we find that the majority, the posters actually hold negative attitudes towards the disclosure of this, the publication of this gene sequencing data. And the green part is actually the positive ones, but within this green, with the positive ones, we've seen that government agencies, media accounts, internet celebrities, so they're like the social media influencers, they hold positive attitudes towards disclosing this information. But for the users holding negative attitudes towards the disclosure, most of them, the majority of them are from the private users. So we call them maybe the general public. And the reasons for the positive attitudes towards the publication includes this is a high quality research paper, and the research findings of these publications are highly significant. The publication contributes to the genetic data sharing and scientific progress. And this publication addressed the long-standing issue of inadequate representations of Chinese academic information in global mainstream genetic database, thereby facilitating precision treatment for Chinese patients. So this is the benefits. What are the reasons against? So the first one, the publication constitutes the betrayal of China. And also researchers' lack of awareness of protecting national security and the genetic information safety. Other frequently mentioned reasons is the researchers pursue their own interests, such as fame, financial gains, career advancement, and university rankings through the publication. And also other reasons, including the publishing in foreign journals, is manufacturing of researchers. What is that? Then a neo-centric minds, which means the foreign journals are better than the Chinese ones. and universities have not effectively reviewed and regulated such international publications. So these are the preliminary results, and I would say based on the patterns of the attitudes showing towards this publication, we've seen the influence of the laws, right? So the laws on the one hand promote the international collaboration, promote the data sharing, but on the other hand, it also it used a lot of legal requirements to set up, the conditions for international collaborations. And also the past years scandals about the misuse of human genetic information gives the general public an idea that this information is critical. It relates to the national security. Actually, this idea has been embedded in the national in the biosecurity law itself. That in regards the genetic information is the biosecurity, and the biosecurity is part of the national security. So all these backgrounds, I would say, give probably result in this type of the patterns towards the attitudes. And also our research find that the general public, the Weibo users, their knowledge towards the regulation of human genomic information or resources is very limited. Most of the Weibo users show the misunderstandings of the laws. So this is very important. Another interesting finding is that most of the concerns about privacy of the genetic information providers are not from individual perspective, it's from the collective perspective. So all of the words describing they're using in their microblogs, this is against our nationals privacy rights and stuff. So it's not basically from the individual perspective. I would say this is maybe likely because of the long time of the experience that China do not have no personal information protection law. So the privacy, what is the privacy? What is the right? It still have the gap for the further education or the social education about the general public towards the privacy rights. So this is the all I want to share with you, and I'm looking forward for your comments and questions. Thank you so much.
Yeah, I think it's really fascinating because what you've shared with us highlights the need for perhaps public understanding of law, in addition to, of course, what might be required in science policy. So with this, look forward to continuing conversation because there's quite a bit to pick up on. Also because being based in Macau, I think your insights will be very helpful to some of the developments here in Hong Kong as well. So with this, just checking in, everyone's okay? Right. Thank you so much again, Professor Tu. So our penultimate speaker for the conference is Professor Jerry Menikoff. Jerry comes to us from NUS, but he has spent many years as director of the OHRP in the US. So very familiar with a number of the principles that we've heard from Edith about yesterday. And my hope is that Jerry would also be able to, perhaps do a bit of comparative work for us with what we've heard from Professor Tu most recently, and of course Professor Cheng on developments in China. So Jerry, over to you. Thanks very much.
Thank you so much, Calvin. And I want to thank the organizers, and of course, thank you for the invitation. It's really great to be here. I'm one of the people who came to this meeting with less of a background in a lot of the concepts in terms of One Health and data justice, and certainly, antimicrobial resistance. And yet it's been great learning from all of you and in particular learning areas of overlap in terms of our work that I probably wouldn't have thought of ahead of time. And what always happens out of these meetings is hopefully after the meeting, you end up doing a lot of the wonderful work. So I'm looking forward to collaborations with people that I've actually discovered we are working in the same space. So again, thanks for allowing me to be here. I'm gonna, as Professor Lee kind of discussed, there is a great deal of overlap between what I'm gonna talk about and that talk. Many of the talks are about, the one part of this area I do know is protecting people who participate in research. I want to also sort of, since we're at the end of, or near the end of this meeting, go back to some of the earlier talks. Mike King's talk about this notion of social justice. I'm not going to use, those words, but I think the concept is still there in terms of what I'm talking about. And again, it's a complicated concept, and I'll go through it, particularly in the US, how it was actually used in a certain scenario. And also going back to the beginning, Ji Ping's talk, appropriateness here, discussing again China and rules relating to protecting participants in research, and give you a different view from the US side of things. Having heard some of these talks, so many people talked about informed consent, right? It kept showing up again and again and again, and it's almost hard to put your mind around this in terms of that there's what it means in terms of a lot of these talks. So again, I'm going to give you the US view of this. Big picture, I've certainly learned how AMR is a really big, complicated problem. And I guess I want to present my talk as one nation's attempt at kind of creating a set of rules that actually are somewhat optimistic in terms of being able to deal with difficult problems, like being able to do sufficient research to solve this problem, particularly in terms of dealing with biospecimens. So, okay. Now let's see if I get this to work. Okay, so One Health and the AMR problem. So employing One Health approach, we're going to need a lot of biospecimens and a lot of data. I'm particularly going to talk about the use of the biospecimens, and the sort of question is that this meeting is presented in a number of contexts. How can we do this in a way that's consistent with appropriate use of the biospecimens and data, that's appropriately respectful of the people whose biospecimens we're going to use, and in particular that is just, whatever we mean by just. And again, as I indicated, I don't know a lot about data justice, but we kind of are using Lynette Taylor's approach as a way of thinking about this. So this is from her article. Perhaps the central question raised by the concept of data justice is how to balance and integrate the needs to be seen and represented appropriately with the needs for autonomy and integrity. What are the implications of letting people opt out of data collection? So again, we're back to this concept that many people talked about, this whole notion of when do you need somebody's informed consent for their data, or in particular their biospecimen, to be used in research. And that's what I want to dig into, particularly giving you just one little story about what happened in the US with regard to this issue. And you can make out of it what you want, but I do think if nothing else, it's an interesting story. So yeah, anyhow, restating this, how important is autonomy in terms of making sure we're doing the right thing in terms of data justice in dealing with AMR, and perhaps autonomy in some cases actually isn't that important at all. So that's here's something completely different take on what I'm going to tell you compared to some of the other countries' views on things. So yeah, I'm talking about the US experience. The US actually has relatively, and I'm talking again about the specific rules on the federal level relating to protecting participants in research. It has relatively few specific rules relating to research with biospecimens. In general, to come under these rules at all, you have to meet two definitional concepts. One is it research that you're doing? And the second, does it involve human subjects? an aside, I'm not trying to be disrespectful in calling them subjects. I think there are some of us actually who think it's better to use the word subject than participant, but that's a separate issue. But in any event, that actually is the term used in the US regulations. So I'm just trying to be accurate here. So secondary research use of a de-identified biospecimen, and that's the main topic I'm going to be talking about here. Biospecimens exist somewhere. They're in pathology labs, frozen specimens, whatever it is. Some researcher wants to use them, maybe to learn about AMD and how to solve the problem. Doing that kind of research classically did not meet the definition of using a human subject, since you were neither interacting with a person to collect the biospecimen, nor were you using private identifiable information. And again, happy to get into this in the discussion where these concepts come from. Now that I'm in Singapore, I contrast it with the Singapore rules, very different approach, maybe closer to China approach, where basically there actually are extensive detailed rules relating to research with biospecimens. And in particular, they relate to transferring biospecimens. So that's where they'll get you. And as part of that, you're going to be hitting probably a consent requirement there. So let me discuss the debate in the US. So for almost 10 years, there was an effort in the US to revise the rules relating to research with human subjects. And the most controversial proposal, I mean, this was a really big deal in the world of people who do research, not just with data, but particularly biospecimens. And by far, I mean, I think about, because there was a public comment process, about 50% of the public comments raised this issue. The next biggest topic was maybe 5% of the comments. This was huge. So it's related to the proposal to get informed consent before using non-identified biospecimens for research. And here's the rationale. This was all, you know, a public change of regulations approach. So lots of documents were released publicly explaining what was happening. Growing body of literature shows that in general, people prefer to have the opportunity to consent or refuse to consent to research involving their own biological materials. I suspect most people probably don't disagree with that as a reasonable conclusion. You say, well, can I do stuff with your biospecimen? Well, it should get my okay to that first. Failure to acknowledge and give appropriate weight to this distinct autonomy interest in research using biospecimens could in the end diminish public support for such research, ultimately jeopardize our ability to conduct appropriate amount of future research with biospecimens. More from the proposal, continuing to allow secondary research collected without consent, places the publicly funded research enterprise in an increasingly untenable position. It is not consistent with the majority of the public's wishes, which reflect legitimate autonomy interests. So I'll get back to that, this notion of reflecting legitimate autonomy interests, but notice this sense of bad things will happen if we don't start getting consent. Notice this rationale seems to be largely consequentialist, utilitarian in terms of the approach. It's not saying that it is per se on some ethical argument inappropriate to use biospecimens without consent, but in contrast, that if you don't get consent down the road, this is going to be a bad thing for the US. And in the US, being able to do appropriate amount of research is a really, really big deal. Obviously, the US is a major player in the forefront of doing lots and lots of research. So there was this public attempt to change the regulations that involves the ability to make public comments. One aspect of this relates to Rebecca Skloot in her book. I'm sure some of you are familiar with this. Henrietta Lacks was the woman whose cells were first used to create a cell line. This is many decades ago. Rebecca Skloot is a really great author. If you haven't read the book, you probably should. It is a wonderful book. It actually ended up being on the bestseller list, like the New York Times bestseller list, I think for like almost 2 years. It was like the #1 book. In the US, books that even are vaguely about science and the nonfiction side don't tend to become bestsellers. So this tells you what a wonderful book it is. And part of it was that it was not just a story, it was a story about this woman and her family, and you got into a lot of cultural issues. poor, very poor family, African American, and basically her cell line generated billions of dollars in profits. Again, it was the only cell line for a long time due to some researcher at Johns Hopkins, being able to use it. And she never even knew, the family never even knew about any of this stuff. So fascinating issues. So we're having this public comment process, and you're able to do public comments. And Scoot, who of course is relatively famous, actually ended up producing an op-ed in the New York Times about this very issue, because again, she wrote about, Henrietta Lacks. And here's what she talks about. She's a really good author, talks about a professor in his schoolroom class, apparently has happened. Medical students, and tells you to unlock your phone and then pass it to one of your colleagues. And wouldn't that kind of freak you out, basically? And the student said, "Are you nuts? Why would I want to do that?" And as the professor said, they wanted to be informed, they wanted to give consent. Now just imagine these phones are the cells in your body containing a ton of information about you. Are you really comfortable with giving those cells to some, evil researcher person, there, whatever else? And as Scoot was noting, this often surprises people that the rules in the US actually allow that to happen, that you would not know it, but some researcher is digging into your genomics or whatever else or something. So she notes that, right? Tissues from millions of Americans used in research without their knowledge, often left over from blood tests, biopsy, surgeries. If your identity was removed, scientists don't have to ask your permission to use them. That was back in 2015, and she was right about that, okay? Hadn't changed between what happened to Henrietta Lacks and decades later. So she ends her op-ed. People have told me about 1,000. Numerous public opinion studies find the same. They want to know if their biospecimens are used in research. They want to be asked first. Most will probably say yes because they understand it's important. They just don't want to find out later. It damages their trust in science and doctors. It makes them wonder, what else are you hiding from me? And all that sounds very compelling, very convincing. Again, she's a really good writer, really good at convincing you about things. So that was one point of view. And again, this is a major point of view because it was an op-ed in the New York Times. I mean, in terms of getting public attention, which is actually kind of hard to, any of you who've dealt with this, getting public attention on a kind of sciencey matter is really, really hard, certainly in the US. But she got quite a bit of attention from this. I just want to note, the New York Times, you often have readers who comment on articles. The most upvoted reader comment I thought is quite compelling. This person is talking about, I wonder if it's not so much the question of consent, but the question of ownership in respect to creation of novel methods or means to combat a disease. And he notes he'd be more irritated if they kind of used his biospecimen to create some life-saving, drug or something, and then charged huge amounts of money. So it actually favored, the really rich. I'm not sure about that aspect of it, but the aspect that he was getting into the money issue, I suspect, is what a lot of people actually find most compelling, that this woman's biospecimen generated billions of dollars in profits and no member of her family got a penny out of that. Interesting. So a very compelling comment here. Now, let me give you the other side in terms of the public comments. There was a huge move on the part of the research community to lay out their view of this. And I think it's a really, really interesting view. And probably the most notable letter came from the head of research at Stanford University. Here's their take. Abbreviated somewhat, we find evidence is lacking to conclude that participants value their autonomy, translated as an opportunity to give written consent over the use of their non-identified biospecimens for possible benefits resulting from innovative diagnostics. This assumption represents regulation by feeling based on anecdote and supposition. This opinion can be countered by similarly anecdotal feedback from patients who do not want unnecessary and bureaucratic obstacles to research studies using leftover tissues or other specimens obtained in the course of their medical care. And you actually saw, again, there were lots of public comments. There were, I don't know what you think, lots, a couple thousand at least, which is big for an issue like this. And a lot of the ordinary people out there were, and you get into issues of who was when Skloot wrote her op-ed, you saw a whole bunch of comments coming in, taking her viewpoint out. Of course, we want our consent required. And then you also saw a lot of ordinary people out there, many people who were involved in the rare disease space and promoting that kind of research, who said just the opposite. Do the research. We want the research to go forward as quickly as possible. Let me give you the tail end of what Stanford said. Mandating, so this is another point, mandating consent for de-identified biospecimens would have very severe consequences. Restricting access to de-identified biospecimens would violate the principles of justice and beneficence. And they're basically pointing out, if you need consent, what happens is you're not going to get the data, you're not going to get the biospecimens from the poor, from the vulnerable, from African Americans, other ethnic groups, because they go to hospitals where nobody's going to pay the time and effort and invest that to kind of, get their biospecimens. And that was what Stanford and many, many major research institutions were saying. And I have no reason to think they were wrong about that. So what happened? The proposal was ultimately rejected. And bottom line, it was actually, again, sort of looking at the comments, and the question was, remember that the proposal was out there because if you don't do this, bad things will happen to the ability to do future research in the US. Well, looking at the comments, it was like actually numerically, more people said, please keep doing this kind of research. We don't want you to impose new barriers. And so it was like, well, you didn't prove the utilitarian statement that if we don't impose this rule, you're not going to be able to do this research in the future. And so that actually is still the rule in the US, that you don't need consent to do this kind of research. Just want to, let's see, one of the core reasons. Oh yeah, and that's just spelling that out basically. That it's not obvious that the public wished what we were assuming in the first place. Let me just end with sort of picking up the ethical aspect of this. Remember, we talked about, legitimate autonomy interests of people wanting to control the use of the biospecimens. I'll get controversial here, quote Julian Savulescu. He wrote about this, what is it, about 8 years ago. This was actually the 40th anniversary of the Journal of Medical Ethics. And he was concerned about some of the prominent failures of medical ethics. And one of the prominent failures he thought was exactly this theme, that kind of medical ethics has not been good enough at kind of getting rules out there saying we should be able to do this kind of research without consent. And here's just a few quotes from what he said. It is legitimate to restrict freedom and not obtain consent when it is in the public interest. Our freedom is restricted by the law all the time. He talked about seatbelts. So too, the use of data and discarded tissue is in the public interest, even if people do strongly oppose it. It could still be used like seatbelts in the public interest. Given the huge advances that come from massive information technology, all patient data and discarded tissue should be used with adequate oversight and compensation systems should any harm result. He goes a little further, a moral imperative to do good research. Each year you delay developing a treatment that would cure a lethal disease killing 100,000 people. It's as if you're responsible for the deaths of those 100,000 people. So bottom line, don't assume the more conservative position of requiring consent is always, quote, this sort of more ethical way to go forward in terms of legitimately doing research. And I think this does tie back to the quote I was giving you originally from Annette Taylor about, look, should people be able to opt out or not out of this sort of thing? And this is approach saying, well, no, if you really want data justice, going back to what Stanford was arguing and many other prominent research institutions, data justice, actually, you get the most just outcome by getting data from pretty much everybody in a fair way, as opposed to allowing people to opt out or opt in terms of this sort of thing. And this is just bringing it back to AMR. You know, a lot of you are experts in AMR. The one theme I think that came through this conference is we really need more and more research to solve a really difficult AMR problem. We're going to have a lot of people dying needlessly unless we figure out what to do about this. And probably a lot of that research would benefit from having lots and lots of biospecimens to do research on. And so the question is, do we need to get the consent of all of those people? And I just gave you what happened in the US in terms of arguments in favor of not necessarily needing informed consent for this sort of research. I think that's the end of it. So thank you. So-
Okay, right. Thank you so much again, Jerry, for an excellent presentation. Thank you. So, hello everyone. I thought I'll conclude with a presentation by Carl and myself, speaking on behalf of both of us. So I'd like to take this opportunity to round up on some aspects of our discussion. So do feel free to weigh in later on. This should also save us a bit of time. I must confess, I constantly run over time, whether it's for class or for conferences. So my apologies in advance. I wanted to speak a bit about this project, which really pertains to navigating a very complex data environment that has recently emerged. So never before have we seen such a development. And I thought I would like to illustrate this in a global health or public health kind of context. In order for us to address a number of issues that have been with us intransigent. For example, there's no resolution, as far as I'm aware, between in an international law context, the principle of sovereignty and cosmopolitan concerns. So mentioned this to Alyssa just earlier on. How do we balance the interests of states and wider global health interest? That there is no clear resolution, and I think WHO has been struggling very hard in a number of public health endeavors, and I think that's one of the main limitations. In fact, it's not just WHO. So if we think about One Health, I think that's a limitation for all international organizations, and this would be to varying degrees reflected in the sort of discussions that we've heard between autonomy and public interest, and more broadly concerns about justice. And I think as far as the ethical foundations are concerned, it's also not very clear. We have heard a number of notions, as most recently mentioned, right? A contest, so to speak, between what would be a stewardship kind of approach. I mean, in a legal context, this would be based on fiduciary notions of trust, which is very different from, in my view, social licensing, because that's more contractual. So, but it seems that as far as the international order is concerned, there is, I think for good reasons, immense skepticism towards entrusting or empowering one single agency. But then we're faced with a very fragmented system with a lot of limitations and a shift in international instruments towards the social licensing kind of or contractual kind of arrangement. And I want to illustrate some of these. What I'm interested to do, working in collaboration with Carl, is to map the terrain, so to speak. Carl is a geographer, some of you may know. So that's that mapping, spatial mapping exercise, but done within a political context. And on my part, to think about the role of law and the rule of law, where all of this would be found. So rule of law, of course, for legal scholars among us, right, you know that it's defined by particular characteristics: transparency, accountability, using law to check on the arbitrary exercise of power. So these are conventional kind of principles that you find within law. And then, of course, all of this should be applied towards advancing socially meaningful projects, including, of course, addressing AMR concerns. So let's have a look a bit at the mapping exercise. I've published a paper on this. Some of you have been very kind to refer to it, but critical comments are very welcome. I thought that looking at what's currently available in the regulatory environment, as well as ethical ones, including the FAIR principles, there is, in my view, insufficient attention on justice and equity, particularly if we're moving towards a social contract kind of arrangement. So if we think about social contract, of course, all the assumptions that apply in contractual law or the law of contract and all of its limitations would apply. Contract law, as we know, assumes a certain capability on the part of contracting parties. And then there would also be an acceptation that contracting parties derive benefit, some kind of benefit from that sort of engagement. But this is not the sort of dynamics that we see in an international environment. And it seems that the law itself, the legal situation, doesn't quite support a just form of interaction or engagement in the international order. So by this, if you look at what the legal landscape is like, and of course this in the international law environment, we have got very fragmented, very targeted approaches, a range of different instruments speaking to different sorts of concerns. So that's the situation, and these frameworks don't necessarily link up in a way that is coherent. So there would be significant gaps. So when we think about the collective action problem, something that that Isaac discussed with us, right? We need to think hard about how to work with this kind of situations. The law has been, and also a lot of my legal colleagues are very comfortable looking at particular instruments. So what we find would be, if you think of these various instruments as constituting or making real particular islands, so to speak, right, pockets. So you've got a lot of work looking into these islands. So for example, if you think about CBD and Nagoya Protocol, a lot of people looking into this. But then beyond that, right, how it interacts, how it interfaces with some of the other legal instruments, it's less clear. And I find that there's less discussion in the literature. So by this, what do I mean? So if you look at these, that imagery, which I quite like, right, these pocket of islands, if you consider them as relatively established legal regimes supported by various legal organizations, how do we make of the water that's around the area? So these are sort of like the unknowns, right? So we've heard from our biodiversity colleagues, wonderful presentations, Serge, Alice, and Chris. So proprietary data is generally unavailable. So we think about the commercial sector. If we think about, of course, the message that that we have got more farmed animals than wildlife on this planet right now, and we know very little, hardly anything about them and practices that relate to them for a number of reasons that Chris has very helpfully highlighted. There's very little in the law apart from perhaps some of the WTO instruments that help us to address these areas. So this is an unknown area. So we can continue to probe all those areas that are already known, but then they don't tell us what that sort of data environment is. And if we look beyond agriculture or farming or production and data from that particular domain, we do have a lot of earth science data. And earth science colleagues basically tell me that they basically have data, they've been generating data for the sake of generating data because that's how the funding scheme has been. So they are not scalable, much of it, and not very interoperable. So we have got useful data floating out there, but not very much can be made of these sort of data. So how do we, if that's true, then I think that's going to be another problem because again, it doesn't help to address, or it doesn't help to eliminate some of the challenges that we're confronted with. So I'm not sure, and I stand to be corrected here, that there's a lot of environmental science data. I mean, we've got probably a lot of helpful data about rodents, about bats, perhaps, but again, the limitations in relation to some other species are unknown. And even within, I'm not sure about rodents, because Sarah should be able to speak more about this, but we've heard from Alice that there's a lot more that could be said about bats. I was surprised to hear that we don't actually know all the bats that we have in the world. Is that correct? Yeah, so quite a bit of, I'm not sure if taxonomic is the right word to use, but obviously a great need to look further and to understand what the natural environment is in order for reasons that Alice has mentioned, right? If we are to apply management concepts properly, we need to know what exactly we're managing. So if we don't even have that, then it's going to be difficult. So I think the first thing, looking at it from a very empirical standpoint, is to understand from a data point of view, what we currently know and what we currently don't know. And also from what we have made visible with data, what have we also rendered at the same time invisible or perhaps less important. So there are all of these challenges that I think if we are to engage appropriately with One Digital Health, that's something that we need to engage with. So we've heard a lot about in the recent presentations, arrangements pertaining to humans. I'm not so sure what the arrangement would be for non-human entities. So very rich discussions on ethical requirements, and we've heard thanks to Stephen and Professor Tung, they mentioned the situation in China in terms of the requirements, and of course, Jerry most recently, some of the very specific requirements that we see in ethical governance of research. But beyond this context, if we look at the general global domain, the IHR, of course, is largely silent about a lot of these things. I thought I'd just quickly highlight what requirements there are pertaining to the generation of data. So this would be essentially in the human health domain. So starting, if we look at the human health domain, then we have the IHR. It's the only instrument, legal instrument in the international law domain, generating a very specific kind of data with very specific notification requirements. But even then, of course, as we have seen in the glass setup, right? I'll speak more about that framework in a bit. There are very clear gaps, informational gaps that we do not know. We do have, of course, the usual provision on respecting human rights, and this, of course, speaking to the consent requirements. But as from the discussion that we've just had, it's still very much an open question how consent could be appropriately deployed to respect persons and beyond. Of course, in the One Health context, then it's not just about respecting persons; it's also about respecting entities that happens to share our environment. So a lot of work needs to be done there, but again, this is just essentially the key informational platform, as I understand it, where the IHR is concerned, and a very successful one. But again, I think helpful to understand that there are gaps, and we have seen this map in a previous presentation as well. So I thought I wanted to pick up on this, and of course, Claire has done a lot of work here. Welcome to contribute to this as well. So if we look at CBD, what I want to focus on, of course, is the fair and equitable sharing of benefit, or the ABS scheme. So essentially what the Nagoya Protocol makes clear, and it's not very different from, in my view, the ethical position in research. If you are to take resource from a particular jurisdiction, then the permission of the sovereign state will be concerned where this particular resource is found. And this, of course, as has been made clear, extends to pathogens. So if you are to remove pathogens from a particular jurisdiction, you will need permission from that particular jurisdiction. And of course, the expectation under Nagoya Protocol is that any kind of benefit derived should be fed back into the system, ideally into environmental concerns. So biodiversity conservation is, of course, one of the key goals of the ABS scheme, or the access and benefits scheme, sharing scheme. So it brings us back, or it highlights two things, of course. Firstly, again, it is contractual, essentially. So if you look at the standard material transfer forms that's part of the CBD, these would be very structured arrangements. We shall see in a bit that under the pandemic preparedness framework, pandemic influenza preparedness framework, a similar scheme has been adopted, very broadly based on the CBD Nagoya Protocol mechanism. But here, of course, as I mentioned, it highlights two things: the contractual, social licensing kind of arrangement, and secondly, it doesn't again quite address justice-related concerns, because if you rely on contractual mechanisms in order to distribute benefits, then it raises again all the distributive justice kind of issues that we are faced with when we have data commodification and sharing on that basis. And of course, it makes a lot of serious assumptions about fundamental capabilities kind of assumptions that we find in, for example, contract law: voluntariness, capacity to contract, intention to contract, ability to contract, as well as vitiating factors. So all the various principles there in private law would apply. So, so for completeness, I thought I'd just highlight, of course, this would be the pandemic influenza preparedness arrangement in terms of the sharing of pathogens and related data. Of course, sensationalized in a sense by during the H5N1 outbreak, Indonesia's refusal to share the pathogen unless there is assurance of benefit coming from the arrangement. So I thought for the group, it might be a good opportunity to attempt to engage with this particular framework because it is one of the key considerations in the pandemic accord that's currently being negotiated. And in terms of I think both an academic as well as policy output, this could be one avenue that perhaps we can contribute to. But otherwise, this scheme itself has had a degree of success. And of course, in the international law domain, there is an attempt to try to broaden this. How successfully it remains to be seen. So this basically would be in the human domain. And broadly speaking, extending to pathogen. And of course, I've already said quite a bit about the Nagoya Protocol and the access and benefit sharing scheme. We do have that arrangement essentially applying to non-human entities. So, so that part is clear. But of course, I've also mentioned the principles. And so there's a lot of discussion. It's a jurisprudential question. To what extent private law, by this I mean for legal scholars in the room, contract law, tort law, as well as restitution. So all of these are private law mechanisms. It's still an open question to what extent private law arrangements are consistent with the rule of law. So ultimately, we are empowering private entities and essentially putting certain questions outside of the domain of public accountability. So if that's the case, then how do we speak? If we are to move ahead with this mechanism, right, particularly in places like agriculture, then how do we ensure that there is sufficient transparency and accountability? Of course, this would be the big question, and who actually is going to arbitrate and to ensure that the goals of justice are served. So I think there are a number of important questions raised. The Nagoya Protocol itself gives a definition of benefit. As you see, this is linked to a very commodified kind of notion. But again, this pertains essentially to a non-human domain. So what we have will be a human domain, essentially centered around issues of autonomy and beneficence broadly understood, and also justice, particular constructions of justice. And then we have the non-human domain. There are, it appears, significant gaps in between, and what the pandemic accord is intended to do would be to bridge this gap. But again, I'm not sure if we can be too optimistic about what would ultimately be achieved in this particular document. So I think that there is a need for greater clarity. As far as the CBD and Nagoya Protocol is concerned, and Claire, you're welcome to correct me if I'm wrong, it is now clear that digital sequence information will fall within the domain of the CBD, and it will be governed under the access and benefit sharing scheme. But if that's the case, then in my view, this approach, of course, there are some benefits, but it also exacerbate some of the challenges in commodification or propertization. So all the challenges that may be linked to a more contractual kind of approach. And of course, it also strengthens the sovereignty principle, but shifting very clearly away from cosmopolitan concerns. So there are clear benefits within that, but then I think, particularly where member states have weak governance mechanisms, will exacerbate inequities that we see in these jurisdictions. And so if we are to persist with this arrangement, my concern is that ultimately, whether we're talking about biodiversity conservation or human health, neither are likely to benefit from a number of these approaches. So I do think that we need to perhaps consider a more than resource kind of approach. We need to treat data, we need to treat microbes, we need to treat our natural environment as more than simply resource that we can use. But what form that should take, of course, is very much an open question. And of course, in international law instruments, I'm afraid there is limited or no guidance at all. Again, just a point on the digital sequence information, but again, referencing this to the pandemic accord that's currently being negotiated, the zero draft makes reference to quite a number of these points, and I think that this is one avenue that we could, as a group, contribute to. So, quick recap in terms of my proposition, thinking about one digital health or one health. So one health, of course, as we have seen from all the graphical representation, it's meant to coordinate, it's meant to support collaboration. But then based on what I can see in law and regulation, there's not very much out there that will support this kind of collaboration or coordination, and the sort of principles that are being prioritized in the geopolitics today also seem to be pulling in the opposite direction. So, so then for legal scholars in the room, I think that's what I'm really keen to do. What exactly can the law do? I'm somewhat inspired by ecology, because ultimately, if you look at fungi, of course, fungi is an important microbe. You see how it actually helps to link up trees within a forest. So we don't see this, but it's well established that they do have a critical role in the evolution of trees itself, and also in linking up trees and other organisms within the system. I think that that's something that law can do. John Dewey, a long time ago, said that if you expect public participation, it doesn't happen automatically. There must be supporting infrastructure. And of course, more recently, this point has been taken up in the capabilities literature. And hence, I was rather inspired by Lynette Taylor's paper. Her work is essentially grounded in the capabilities approach. I'm also rather inspired by Martin Nussbaum's recent work in terms of justice for animals, thinking about non-human entities, and what this could mean in terms of our ethical obligation and potentially also legal ones. She hasn't gone so far to include microbes, so I thought that perhaps that might be another living entity to consider. So, so just some very broad points, hopefully linking up with some of the discussions that we've had today. Obviously, discussions about public participation, we've heard from Edith, we've heard from Kalina, very important elements that we want to draw on. And also how to use all of these data within particular technical modalities, AI, of course, being the focus of our presentation earlier today, things that Rohit and colleagues have shared with us, including Celine in a very Hong Kong context. So, so some possibilities. I thought that these might be avenues that we could potentially take up. But again, these are just essentially recommendations. I think that as perhaps a somewhat more tangible output that could come from this meeting will be perhaps an edited monograph of some sort, a special issue. So that I'll be reaching out to everyone. But we need to frame it in a particular way. Of course, where my project is concerned with Carl, we're keen to think about it from a benefit point of view, because it seems to us that that's how international instruments have been structured around. And I think when you deal with member states, it's not a very surprising stance to adopt. Ultimately, if you talk to the public, they'll say how I could support your even public focused initiative, but ultimately, what benefit would come back either to myself or to the broader community, as we have seen, if it is, in a recent slide, to be I think it was Rohit who mentioned this as well, if you're going to attach a huge price tag to my contribution, which I've given out of goodwill, then I'm not prepared to engage. I mean, that's the point. Whether it's individuals or member states, as we've seen with the H5N1 situation, that particular point is clear and I would think also commonsensical. So with this, very happy to hear your thoughts on this. We do have a few more minutes. I think maybe about 10 minutes, and then proper end of the conference before proceeding to lunch. So I greatly welcome your points, your thoughts. While many of you know that I will be relocating, I still do have a research link with HKU. So I still maintain a research collaboration with this institution. So a somewhat different setting, but I think still in the position to move developments. Yeah, so just a quick note to thank everyone.